Dr. Maitreyi Murthy is a movement disorder specialist. She completed her MBBS from Sri Siddhartha Medical College in India, then went on to pursue an MPhil at St. John's Research Institute. But somewhere along the way, she realized her true calling was clinical. To be with patients, to help them reclaim their lives. She shifted gears, completing her neurology residency at Rutgers, New Jersey Medical School, and then earning her fellowship in movement disorders from the esteemed Johns Hopkins Medical Center, one of the most respected programs in the world. And joining her in this episode is someone who's become a name of legend in the field, Dr. Sharan Srinivasan, famously known as the guitar surgeon for a surgery that stunned the world. A guitarist awake on the table, playing music while Dr. Sharan operated on his brain. That guitarist was Abhishek, diagnosed with focal hand dystonia, a rare, crippling movement disorder that robbed him of his art. Dr. Sharan brought her guitar into the OT and precision into the impossible. But it wasn't just dystonia. Meet Shivanna, a tailor, a man of precision. Parkinson's stole that precision from him. His hands trembled, his control slipped away. He first came to Dr. Sharan Srinivasan in 2019. With a mixed type of Parkinson's, he underwent stereotactic surgery on one side, and the results were life-changing. He was so moved by the transformation that in 2021, at the peak of COVID, Shivanna came back. Not for a consult, but to ask for the second side to be done. For the first time in the country, after a patient voluntarily requested, a bilateral staged lesioning surgery was performed by Dr. Sharan Srinivasan. And Shivanna, he got his hands back. He's returned to tailoring. And today, he volunteers at a prestigious hospital in Bangalore, helping others like him. Even in chaos, even under pressure, his tremors never return. One of the most visually stunning surgeries was for a woman named Jayama, an elderly patient with Parkinson's. She came with disabling tremors, and right there, on the operating table, the tremors stopped, instantly, dramatically. A few years later, another story made headlines. Joseph D'Souza flew down from the US after seeing those very videos. Because no one in his country could help him, he left India with hope. We named it A Love Letter from the USA. And this is how Mr. Joseph sounds now. And in the spirit of Parkinson's Awareness Month, this conversation becomes even more urgent because Parkinson's doesn't knock. It arrives quietly, slowly stealing movement, speech, and independence. But there's help, there's rehabilitation, there's medication, and there are surgical options that can help people live a near normal life with Parkinson's. When done right, treatment can be life-altering. As we grow older, these disorders become harder to escape. But with the right information, with the right care, we can add years to life and life to years. If you have parents, grandparents, or loved ones struggling with tremors, stiffness, or slowness, this might be the most important thing you watch all year. This is Rebooting the Brain, and this is the episode you didn't know you needed.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവം ഉപാസ്മഹേ ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences.
Namaste, everybody. I'm Dr. Prathiba, host of this show. I want to start this episode with a prayer. Asatoma sadgamaya, tamasoma jyotirgamaya, mrityormamatam gamaya. Om Shanti Shanti Shanti. As the shloka says, we have our esteemed guest who's going to throw light on this very heavy subject called neurosciences. We have Dr. Maitreyi, basically a very passionate Indian, but trained in the USA. So she's come here to make us understand what is movement disorder all about. She's a movement disorder neurologist. So, Dr. Maitreyi, can you tell us a little bit about what movement disorders are all about and how did you go about training with it?
As I was introduced, I'm Dr. Maitreyi. I did train with MBBS here in India, but then I went on to the US to complete my neurology training. And then during the training, we tend to pick different subspecialties. And there wasn't a particular it's not that I saw too many patients that got me interested in this subject, but I was just drawn to this field. You see elderly patients, and there's so much to this field, and it's so vast that I think something there drew my attention, and I decided, this is what I'm passionate about. This is what I want to do. So then I applied for a fellowship, and I fortunately got to train at one of the best institutes in the US at Johns Hopkins, and I did my movement disorder training there for 2 years. So when you talk about movement disorders, it's in the name. So there is
Right.
a problem with bodily movements, and these can broadly be divided into two kinds. So there is a reduction in movement. A classic example that anyone might think about is Parkinson's disease. When you think about a patient with Parkinson's, you see the typical patient who
Right.
is slow, who's deliberate. They struggle to do regular things.
Like
That's
a
your
slow-mo.
that's
They're
your
in slow-mo.
correct. So that is just one part of it, and then you have disorders that have excessive movement. There is a host of disorders under that heading. So I think as we go along today, we can sort of maybe discuss a little more about Parkinson's and the similar disorders. I think our goal for today should hopefully help our viewers kind of identify, okay, there's something wrong. I need to see a doctor. It's not just age-related things. I hope we can kind of deliver that message. You often hear that, oh, there's no cure. Like, what's the point? But no, that's where you need a doctor. You need someone to guide you to lead your best quality of life. So identifying the problem first, knowing that there's something wrong.
True.
I think that's where we need to come in and sort of educate the public that's where the need of the hour is.
Yes, absolutely. Now, coming to the contrast, Dr. Sharan, you trained to be a neurosurgeon, movement disorder neurosurgeon. So, between a movement disorder neurologist and neurosurgeon, can you throw some light to our viewers? What do you actually do?
Sure. So, hi everybody. I'm Dr. Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon. So, functional neurosurgery is a subspecialty in neurosurgery. Like we have skull base, vascular, spine, pediatric. It's one of the newer specialties which needs a multidisciplinary approach, where the surgeries that we do is mainly focused in helping to improve the functioning of patients, those who are dysfunctional,
Correct.
for various reasons. The commonest things that come under this heading is surgery for movement disorders, surgery for spasticity, treatment and surgery for pain, surgery for epilepsy, and surgery for psychiatric disorders. So that's what is functional neurosurgery all about. So I trained to be a neurosurgeon back in Namma, Bengaluru. That's what I did. And then I worked as a general neurosurgeon for many years before I decided what I should do. And somewhere along the way, I got this interest to do functional neurosurgery. And then I went to Tokyo, Japan, and trained under the best in the world called Professor Tako Metara to do this work. And once I came back, I established a functional neurosurgery program. And we have a great program running right now, helping hundreds of patients get better. So I'm hoping that between us, we will be able to show you where medically from diagnosis to optimal medical treatment is possible from the neurologist, and where we think it's medically refractory, or where we think that somewhere the quality of life is getting impacted and not adequately treated just with medicines, does surgery have a role to play? If yes, what surgery and how much and when?
And when do you do
Yes,
it?
that's basically what we'll attempt to achieve in today's conversation.
I think that's going to be a lot of information for our viewers, right? But before we get into the actual depth of this, can you tell us a little about how you went about with your training, and maybe a little about your MPhil that you did also?
Sure. So I think by the time I was done with MBBS, I mean, I was very passionate about being in the neuroscience field. And that was way back when I was probably around 10 or 11. I remember this article in the newspaper with the Indian Express, There was this article about Sir Einstein's brain. And
Okay.
how he was a genius because there was really a structural difference in his brain. I read that and that caught my attention. And
Okay.
somewhere, from that point on, I was really fascinated. And there was something, I wasn't sure, I wanted to be a doctor for a long time, but I also got interested in research in between. So, MD, PhD programs are offered in the US. So I think I started off with that idea. But, in India, at least back then, research is not something that's a part of your education, right? So I really wanted to get some sort of experience, like what is it? Like, how do you go about it? So that's how I ended up doing an MPhil program. It's not, it wasn't in the neurosciences, because I did try to apply, but it's funny that it wasn't encouraged. So
Okay.
it's as a doctor, yes. Because
Really?
they prefer, there was sort of a preference for the basic sciences going
Oh.
into, so
Okay.
so that was sort
Was
of
that just to make sure that others get a chance, or
maybe.
It sounds like that to me. I mean, otherwise it makes no sense.
it was kind of implied, but anyway, but it's okay. It didn't deter me. I still wanted to go about that. So the MPhil was actually in infectious diseases. So I did some work in tuberculosis and things, but at least it introduced me to.
So where did you work this? Was it in the US or was it
No,
in
it was
India?
here. So in India, I worked with St. John's Hospital. I used to work. Yeah, so there was a project going on in, this was a larger trial, and my study was just a small part of that. So we, the work was mostly seeing patients here, recruiting patients with TB, and it's sort of a vaccine trial. That's what it was. But the academic part, we did it in Norway. So it was the MPhil was taking classes and writing your thesis. I presented my thesis there. So it kind of gave me an introduction, but there was a lot of things I learned during that process. One, yes, I mean, research was it was really nice. Like, it was something different. It wasn't easy. That's another thing. But I think when I was working here, you're in the community, right? You're going to see patients, and I kind of felt that, that's what I like more. Like,
Okay.
You belong there.
I want to be more in the community rather than, there's nothing, I'm not saying,
That's
of course,
true.
I really support research and all that, but it's just, I felt like my calling was more being in the community. So then I figured, okay, maybe MD PhD is not the way to go. So then I realized, okay, let me just go about doing neurology. And again, back then, the Indian system was a little different, it's a rank based. And so I wasn't certain whether, whether
Right.
whether I'll get it or not. And that's the only thing I wanted. So I felt that way the US was probably a better choice. And that's how I took my exams. And I'm glad I got into neurology and then completed my fellowship also. So.
Really interesting.
So since you moved from here to there, I'm sure you had your ups and downs during your training period. So would you like to tell us a little more about?
Well, it is difficult as a trainee, long hours. And then
It
it's a
better be
very
difficult,
different system.
let me be honest. I always
Nothing comes
yeah.
easy. No, I know that. Nothing comes easy. But I mean, and then, you're away from your family,
that is
Exactly.
those
That
things
is
definitely,
tough.
you're by yourself, you're alone.
True.
You're fighting everything on your own.
True. That I agree.
But you do make friends, people are supportive, and there's a lot of pressure on you, to
You have to prove yourself different country
absolutely.
and all of those things.
And then, absolutely. So It's enjoyable. I mean, I feel fortunate that I got to do what I wanted because I do know people who couldn't.
Okay.
So, or hard work is one thing, but to achieve what you wanted is, I
Correct.
think, is something
And
else.
realizing your
So,
dream is
yeah,
not that easy for everybody.
absolutely true.
So, do you want to tell us a little about your training when you went to, the neurosurgical training and then probably the functional neurosurgery part of it?
Sure. So the little bit is like Maitreyi said, I want to be a neurosurgeon from my 8th standard. So I'm also living my dream. And why? A lot of people ask me this why. And why is because my mother used to subscribe to the Reader's Digest magazine, and there was a series of articles about the brain, things related that sort of got me interested. The first was an article. They run a section called Drama in Real Life,
I remember.
and that would be one of the first any new book comes, that would be the first thing I would read. Something real, something that's happening, and there's a lot of excitement.
Correct.
Though I'm reading it, you can sort of visualize what is
Visualize the
going
whole
on.
thing.
It's very very vividly written. I would
Correct.
love that section. That and life's like that and laughter the best medicine. These are the three things I definitely would read in the book, if not anything else. So that particular segment that day was on a lady who was skiing down the Swiss Alps, and she fell unconscious, and then she was airlifted with a helicopter. And I said, oh, at that time in 1980s, helicopter and all lifting in India was like unheard of. So I said, oh, that looks very very fancy, science fiction type. And they took her to the hospital. They found that she had an aneurysmal bleed. That's the first time I got introduced to the word aneurysm there. And they did what they did, and she got well. So that was the first impact. Oh, that can happen, that you fall somewhere, go somewhere and get better. Second one was, the life of a neurosurgeon. He was a Canadian neurosurgeon, senior Canadian neurosurgeon, who was treating, children with brainstem tumors. He was one of the best guys in that. And he was talking about how some of the impossible surgeries were being done. And he was talking, what fascinated me was he had three people to deal with: the child, the parents, and the grandparents.
That's true.
So, that was like, I didn't realize that there's so much of dynamics going on there. So I realized that I was living in a joint family, so I know what a grandparent, parent, all of those things. So that was there was a third one on the brain itself, how much is not known about the brain. So I said, this is done and dusted. I want to be a neurosurgeon. And I chased my dream. I did what I did. And I got there. And then as I was sort of coming towards the final year neurosurgery, this fellowship is a very common thing that you hear in super specialty practice. Where are you going? What are you doing? Things like that. So I also got into that sort of cycle of looking at it. But I always look at life differently because I don't want to be the run-of-the-mill guy who's doing this. So I just sort of zoomed out and see what's going on around me. I realized that most of the people I knew who did the fellowship immediately after they passed, because that's when they're not yet settled. Not a bad plan, but more importantly, they came back and did nothing about the fellowship except it was on the visiting card. And apart from that, they're doing the same old stuff. Apart from that cribbing and crying, saying that India is like this, US is like this, this and that, and it's so bad it is here. Back in the US, I was doing. I said, guys, why are you crying? So I didn't want to
Very
become
contrary to what you said.
I didn't want to become a statistic. So I decided, let me do hardcore general neurosurgery for 5 to 6 years. Let me see what I'm good at, what I'm not good at, what I like, what I don't like, and then I'll make up my mind. So I got into the practice. I started doing what I was doing and started building the whole stuff. Somewhere 6th year, 7th year, I started asking myself, what do I want to do? Initially, I got interested in epilepsy surgery and I started exploring that. And then that morphed into a larger picture of functional neurosurgery. And then what happened was, it was in 2008, 2009, I had actually applied to do a fellowship in Milan in Italy. And that fellowship had epilepsy also. And I was to start the fellowship in October of that year. And in August of that year, the financial crash happened, the Lehman Brothers crash happened. And then I got a mail from them saying that we can't fund you because of all this. If you can come yourself, you come. I said, who's going to go with that kind of money? At that time, I couldn't afford that kind of money to go and, displace myself and stay at my cost. So I gave up. Continued practice. Then I was started to get a little depressed, wondering, where am I going to do? What am I going to learn? Where am I going to learn? All of those things. And then around 2009-10, my sister, who lives in US, she's a speech language pathologist. She also got into spirituality. Okay, so she came for a usual visit. So I was telling her, I don't know who my guru will be, what's going to happen, where do I go. I didn't want to go to North America to train, though there's a huge opportunity because I felt that the technology there was too expensive for our country people to afford.
Yeah.
So I said, if I can't get back something skill that I can do it here and impact my people in this country, there's no point learning that skill.
Correct.
So I was sort of, I didn't know whether there was another option, but I was just looking at it like that. So she taught, then when I told her this, she introduced me to a set of shlokas called the Guru Stotra, which is written by Adi Shankaracharya, a set of 12, verses. She said, please read this every day and seek your guru. That's what she told me. So I said, okay, seems to be a plan. So from that day, for 4 years, every single day, I read the Guru Stotra and said, God, find me my teacher. And I did that, and I would attend conferences connected to functional neurosurgery. So February of 2014, there was a workshop held by AIMS Delhi. And that was on a workshop on spasticity and pain, which also had a life surgery segment. And so I was sitting in the auditorium and they had a life surgery feed from the OT. Then I saw this surgeon for the first time on the screen there, Professor Tako Maitreyi from Japan. I had never heard of him. Okay. And I saw him there, I saw him speak. And 10 minutes into that, I said, he's my teacher. I don't know what connected, it just connected. And then I waited for him to come from the OT. He entered the hall. And everybody, he was like the superstar that everybody jumped on him. And I also was one of those guys waiting eagerly for my turn to speak to him. And then, everybody said whatever. Then I introduced myself. And I said whatever. And Japanese, they're very shy guys. They hardly speak. I said, I want to do a fellowship. He said, okay, send me a mail. That's all he said. He gave me a card and disappeared. I went urgently to my room in the evening. And I started writing a mail before he forgets. I can't even write I'm that Indian guy because everybody was Indian then. If I was at least abroad, I could say that.
True.
So I sent a mail. I said, I had spoken few words. I hope he remembered that. I sent a mail to him. He mailed back saying that, so you want to come for 2 weeks or 3 weeks? Because most people go for a very short period, more from India when they come. That's what he seems to be. I asked him this later. I said, I want to learn 1, 2, 3, 4, 5, 6. I put up a list there. How long do you think I should come? I asked him this question. He said, you should come for 6 months. I said, done. And that's how I found my guru. I found the connection and things like that. And I went there in 2015. You know what's amazing? The training was free.
Wow.
He didn't charge 1 rupee for the training. That was unbelievable.
I think that is God sent.
I only had to spend...
Right.
I had to
Not easy.
But how do they, 2 weeks, like how do they teach something?
No, I was there for 6 months.
No, but you said generally
people just come, observe and go.
Okay.
Yeah.
See, that's the catch. They just come, observe and go. They don't sink into the subject. And that's what most people just pretend they're doing these things, more often than not. So I had to spend for boarding lodging, but that was amazing. And the way he trained was incredible. I think he's a genius. So for me, it was like God's work, what I had done.
True.
And, I sorted out, I got it. It came free, things like this. Then I said, how can I give this back to my people who can do that? And that's what my quest happened to start functional neurosurgery.
Great. Now that we got a lot of background of your trainings and what you've gone through to do that, now I think it's time to go a little in depth to the subject to understand from both your perspectives, how do you, first of all, what are all the different disabilities that you get because of these movement disorders? What are all the things that comes under it? And how do each of you handle it? Like you as a surgeon and you as a physician, how do you look at the patient, triage the patient? When do you decide that you need each other?
Sure.
Right? Yeah.
So if we start with Parkinson's, which is,
Yeah.
the commonest kind. So there is a word we tend to use. It's called Parkinsonism.
Hmm.
It's sort of an umbrella word.
Maybe you
that
should give a
describes-
clarity of
Yeah.
what's the difference.
Yeah. So when I say a person has Parkinsonism, I'm looking at a few things. Usually there is a tremor in the hand, a tremor like shaking. That is at rest, meaning they're not actively doing something. The person is just sitting quietly watching TV, or they're just walking. They're not swinging their arms, and you see their hands shaking. That's a prototype patient someone would imagine, if someone has Parkinson's. But that's not there for everyone. So you don't have to have all these features, but usually a combination. But what's usually the hallmark of Parkinsonian syndromes is a slowness. There is a reduction in movement. Sometimes they don't move at all. That's a very classic symptom. So you have that. Then you have a certain stiffness in the body. Stiffness in neurology can mean many different things.
Yeah, true.
Spasticity is stiffness from stroke or other reasons. Stiffness in Parkinsonian syndromes is called rigidity because there's a certain kind of, when you move the limb, there's a certain resistance you feel. So those are some symptoms. And then you have something called freezing. So, these patients sometimes when they're trying to walk or, they just can't move. They're like stuck in place. It takes them a while to get past that. So that's another thing you see. Falls because they lose their sense of, their center of gravity sort of shifts. So they have spontaneous falls. Like it can be inconsequential. Like, I bent over to pick something up and I fell. Or I don't know how I fell. That's a very common thing you hear. They don't know how they fell. So losing that sense of, they're called postural reflexes. Like for you and I, if we were about to fall, we have we can brace ourselves. They lose that. So usually it's a combination of these features. So Parkinson's disease is one of the causes of Parkinsonism. Then you have a host of other disorders called atypical Parkinsonism. So what does that mean? It's not Parkinson's disease as such. In the beginning, they can all look similar. It's important to make the distinction because someone with Parkinson's, you can expect, usually, if they don't have other comorbidities, by Parkinson's itself, 20 years, maybe more. These other disorders do shorten the lifespan. So it's important to understand. And they are more quickly progressive compared to someone who has Parkinson's. So it's very important for people to understand where do I put this patient, right? And how do we identify? So when you think about atypical syndromes, what I'm looking for in a patient is, do they have red flags? So what are these red flags that I want to pick up on? So when I hear their history, I ask them, okay, when did the symptoms start? If the prominent complaint is falls, like balance impairment falls, then you're thinking of another condition called PSP. Very, very difficult syndrome. But, not that Parkinson's patients don't fall, but it usually comes a few years into the disease. It's not the first complaint. And then people with PSP tend to have...
So can you elaborate PSP for our viewers?
Sure. So it's a progressive supranuclear palsy. It's named that because the hallmark of this disease is they also have problems with their eye movements. It's the part of the brain that controls your eye movements, especially looking up and down. So it's called vertical gaze. So they tend to lose that. It's gradual, and common complaints with that would be, they can't go up and down a staircase because you can't look down. They can't read. When they're eating, they make a whole mess because they can't see, But you have to learn to elicit these things.
So can this be mistaken for a eye-related problem from the family?
Absolutely. So, and these disorders, PSP tends to occur a little bit sooner than your regular Parkinson, probably 50s or 60s, whereas Parkinson's can happen even at 80. So, that, and that's why you have to be vigilant. And if something doesn't seem right, go to a doctor. Like, don't dismiss it as, I'm growing old.
That's important.
But exactly. But see, age-related changes also happen.
That's the problem.
Because people as we grow older, up gaze, like looking up, is gradually, we lose that. So it can look like that. But there's other things that tell you, like, of course, people fall. But if it's an everyday thing, that's not normal. Like, that's not just age-related. Something should be going on. And then the way PSP affects people, they can also have a lot of behavioral changes. because invariably dementia is a part of this syndrome. So, behavioral changes, like everyday things, so those are things to be
So, how
mindful
early
of.
do behavioral changes come in these kind of patients?
Um,
Is it something that you see early enough for the people to pick up and come to a neurologist, or is it something which comes in later on?
I
What are the first few things that you would want to tell our viewers? Like, if you find these things, don't wait, just go and meet your doctor types.
the physical aspects are what we discussed. There's a slowing, or if they start to have choking out of nowhere, they're not
Right.
able to swallow food. These are physical aspects. Behavioral aspects are a little difficult because you're thinking, okay, they're growing old, they're not pleasant anymore. It's common for any of us to think
Right.
that, right? But this PSP causes sort of what we call a frontotemporal syndrome. So behavioral changes, I'm sure you can
Yeah.
elaborate more on that, is very typical. So just getting angry easily, impulsivity, like they can't, you tell them, please just wait for me to come back, I'll help you. No, they get up and go and they fall. So that those sort of things, those inhibitions are not there. So it is a little difficult to identify, but I think the motor aspects are more easily, people see it. People see it.
And earlier also, I guess.
Yeah, exactly.
Earlier
So
than
those come on
behavior.
earlier. So that is
Right.
one type of
Just want to add
atypical.
here, see, what is key is, unlike acute neurology where it
Right.
can happen suddenly, these are a very slow,
Very subtle.
progressive,
True,
subtle,
true.
and sometimes it's not consistently present.
Correct.
It
Correct.
can come in sometimes, not be there sometimes.
I think that's why we are spending this kind of time to, dissect it out and say to our viewers, so that if they have certain people in their houses like this, it is important to reach out for help.
So what I was trying to drive the point home is, there is the patient himself or the person himself, he should start observing something is going on. Sometimes that doesn't get picked up early enough because imagine it's like you have a smile limp, you may not even realize yourself.
Right.
But then the people around them should also be observing something is not okay, and ask them first, and there's a denial that's going on, and sometimes it goes on. So this is very important for us to at least have an eye on it. And you don't have to jump on day one, but if you feel that there's some pattern going on, there's something doesn't look okay, then I think sooner than later it's better to go and at least check it out,
Yeah.
make sure nothing big is going on, catch it early, because anything you
Correct.
catch early, obviously, we can
It
do
can be
much.
helped.
Yes, I mean,
And
we are
especially
before.
these disorders, because they
Yes.
kind of shorten your lifespan.
True.
So
And quality
it's
of life. See, the
important to, yeah.
key is a QL. The quality of life is the impact.
I
See,
think
today,
so.
with good medical care, we're able to keep people alive for longer.
And more comfortable.
Yeah, but the question is, that comfort is the problem. So the question is, as you start retiring, as you start sort of winding down your life, you want to be at least enjoying it.
True.
But then you're only struggling to even get up and go to bathroom, do this, do that. Then, and live that for another 15 years. It's not worth the effort.
Correct.
That's when each of us also have to take responsibility to make sure that we check on our quality of life as much as the duration of lifespan.
So moving next in the Parkinsonism, Parkinson's disease, in that spectrum, what else next?
So PSP is one of it. Then we have something called MSA, multiple system atrophy. So it's this is another type of Parkinsonian syndrome, devastating syndrome. Again, affects people slightly earlier, 50s, 60s maybe. The hallmark of this condition is what we call autonomic dysfunction. So to elaborate, it's functions that we don't have to have control over. Like, when we stand up, our blood pressure, changes.
Right.
When we, make postural changes automatically. We're not thinking about these things. Our heart rate changes. Urinary function. We don't have to think about these. So those are the ones that get hit first, usually. And MSA has two divisions to it. It's hard to identify them sometimes. Some of them are more Parkinsonian, so they look like a Parkinson patient. There is another cerebellar variant. So people look more like they have the cerebellum is the part of the brain that controls coordination. So that becomes their main issue. So the distinction
So what
is
kind of symptoms would they show?
So they usually start off with these autonomic issues, and then they have balance problems. Again,
Okay.
falling.
Yeah.
They may have that the clumsiness to their gait, which looks like, if you think of a person who's drunk, that's
Right.
what they look like. So it's not clear cut always, but it's a very difficult disease to deal with, and they invariably have sleep related issues. There's something called stridor, difficulty breathing, specific noise they make when they. So these are all Quality of life is very difficult with
What about-
MSA.
Sorry.
Go ahead. No, go ahead.
They also have a lot of cognitive issues in the beginning.
I was coming to that. So earlier, it used to be thought that, when you're thinking of these Parkinsonian syndromes, if somebody has a cognitive issue, they're like, it's probably not MSA. But that thinking has changed because we still know that people with MSA are, again, they do have cognitive issues, but not as profound as the other ones.
I'll tell you why I brought that up. Because a lot of patients get referred. See, I do functional neurosurgery. Many of them come directly referred to me for surgery for Parkinson's. So that's the question I have. The first question I have to have is I have to do a pre-surgical evaluation to see whether he is the candidate for surgery.
Right.
And one of the first questions I ask is cognition. Because the moment I feel that cognition is affected even subtly, then I back out. Because I know that there's nothing much.
So you mean to say they don't qualify for your surgeries?
Yes, because the surgery, which I will talk later, is more for the motor symptoms of Parkinson's disease. So we also have to know the inclusion exclusion criteria, who qualifies, who doesn't qualify. Because all these are clinical decision making. There's not a scan based decision making like a tumor in the brain I need to take up and things like that. That's what makes this field so difficult.
True.
And it's not a black and white process at the end of the day. There's so many variables you cannot imagine. And the amount of patience that doctors require, forget about the patients requiring patience.
Yep.
And they are impatient. We have to be extra patient. What is going on. They want magical results like this. And, it's
setting
not
the expectation is very important.
You can't imagine. And strangely, some of them already come ready like baggage. Okay, chalo, tell me what are you going to do next. And as a surgeon to tell him that I'm not in a hurry is quite actually contradictory to this whole process. So it actually tests a lot of my patience, because in an emergency you're running.
Yeah.
Here you're actually slowing down to make sure that
you have the right patient.
Data that is happening. So it's quite a challenge.
Do you sometimes encounter patients coming and saying to you like, old age, so they become slow anyway, their mood goes off anyway, the cognitive function also can decline anyway. So do you encounter this?
That's very common, yeah, and that's why people don't seek attention. I
Exactly.
think that is. I hope that's what we can convey to them. That
True.
None of that. I won't deny any of that. With age-related changes, these things do happen. But there could be other subtle things that we're not picking up, or if you're more vigilant, you might see that things are different. So
it's good to consult and rule it out and say it is age-related and nothing to do with this, rather than missing out.
Yeah, it's not so clear-cut sometimes. I mean, how many 80 or 90-year-olds do you see who are actually doing so well in life, right? I mean, they have minor constraints, but if they can get reasonably well, they can go about their day without much help.
Right.
No, I agree with you because I'll tell you, see, recently I operated a 91-year-old man. And that Tata was so hyperactive, you cannot imagine. He's from Guru. He's a president of this temple, something from school and this and that. Man is like hyperactive, you cannot even imagine. And he doesn't look 90 first of all. And he is firing his two daughters because they think they're restricting him and things like that. He was riding a scooter, imagine 91 years, without a helmet. He's fallen down, he had something, he came with a subdural hematoma. He's got subdural. And he suddenly started having some memory lapses, and then they realized something was going on, and he had a subdural. 91 years, very few people want to touch this guy. Then I operated him, and then he got better. And I told him 1 month rest. He didn't listen to anybody. Some general body is there. He ran away to Guru from Bangalore. Then some other fall happened. He came back with a bigger subdural bilaterally.
Oh my God.
And then what to do? He came wobbling into my outpatient. And then I told them, see, now I'll do middle meningeal artery embolization because can't keep on operating this guy. And we went in to do the middle meningeal artery embolization. What happened was the vessels are so tortuous, we couldn't embolize the guy. Then I told the family I'm going to operate. So this side returned, both sides are removed, the hematoma in the same city. And people, that anesthesia thought I was nuts. What are you trying to do on a 91-year-old man? His Tata is completely all right. In 6 months, it's up. So what I'm saying at the end of the day, so if you look at that guy and say you will be slow, you'll be this, he'll say I am faster than you.
Yeah.
So and you see a lot of people like that.
Very true.
And so all I'm trying to say is that it's not all under one basket you do that. I believe, and that's one single biggest message I want to give the public. Don't put all of this under the age basket.
Correct.
Please go and evaluate, because if you have a treatable cause, the smartest thing to do is to get it treated.
Very true.
But if everything is normal, then we say it's a default diagnosis. Say, oh, if everything is normal, maybe it's age related, and then we sort of accept that and go.
Correct.
That's the single biggest message I want to give right now, because otherwise we'll be doing a disservice to ourselves
Correct.
and the family
Yeah.
around us.
True, absolutely. To just finish the other two, there's two other disorders.
Oh, okay.
So dementia with Lewy bodies, which I think we can reserve a separate segment.
Yeah.
Again, very difficult diagnosis. Not for for the person who's dealing with in the family, but that, and there's something called corticobasal degeneration. So these are like the atypical syndromes. So usually when you see the patient for the first time, it depends on what they came with. If they have a clear resting tremor, and I've done the exam and I've determined that they have Parkinsonism, and then I'm looking for these red flags. Say on the first meeting, I don't identify any red flags. Even then, you don't want to sort of give, so we call it idiopathic Parkinson's disease if I think it's none of these other things. But you don't want to be so certain yet, because all of these disorders can look very similar in the beginning.
Agreed.
Right.
So we wait about 2 or 3 years to kind of determine that, okay, you're going this way, not the other way. Because otherwise, imagine, say this patient had PSP, and then you kind of tell them, this is most likely looking like Parkinson's disease. And then it's 3 years, their lifespan is about 7 or 8 years, So, and I'm not saying it's not clear cut all the time. So we give that timeline to see, making sure that it's not becoming something else.
Correct.
And patients always understand that,
True.
as long as they know you're doing
And
the right
you
thing for them.
explained enough to them, I think so.
That's the
And-
key. The key is in this field, more important, you have to explain, spend
True.
that time.
Spend that time.
Tell them why you're saying what you're saying, not that I'm not sure.
Correct.
But the disease presents
Exactly,
like
yeah.
that. They should not say, oh, my doc looks unsure what's going on.
Yeah,
You
it's
know,
not
he's a
that
new
I'm...
recruit,
yeah,
it's like,
exactly. It's
that
just...
should not happen.
True.
The disease presents that way, and that's why
Exactly.
no question.
That's right.
So then it's symptomatic management. So in general, because it's a Parkinsonian syndrome, you can start with dopamine therapy. As a Parkinson's patient, they respond very well. For the most part, they respond pretty well. PSP patients and MSA patients also, not maybe as robust as a response, but they do. But in MSA patients, you have to be careful because levodopa, which is the dopamine medication that we typically prescribe, it drops your blood pressure. So an MSA patient is already struggling with that. So we have to be careful, give small doses and monitor their response. So, and it's everything, whatever other issues they're having. Common again to all Parkinsonian symptoms, you have constipation. Like these are what we call non-motor symptoms. So the motor symptoms are what is physically visible to everyone. Non-motor symptoms are actually more disabling to the patient.
True.
There are so many things.
Right.
So managing those symptoms, we have to ask. Not everyone will readily tell you that. Like if
They don't even know it's
they don't
part
even
of
know
exactly
it's part of it.
And you
Absolutely.
can't
that
blame
is
them.
the problem.
Correct.
It's coming from everywhere. They think, how can this be? How can this be? How can this? They're coming from so many different. They wonder what's going
Correct.
on.
Yeah, I mean, if you have constipation for the last 5 years, you're not going to see a neurologist. You're going to go to a GI, a primary
Correct.
doctor, maybe a GI specialist.
And they don't
There's a
even think
study,
it is sometimes
a study
related to
which
it.
came up to saying that constipation was the earliest signs of starting a Parkinson's.
So
I
they are
remember
called
some study.
prodromal. So when we check, so when I see a patient, I'm usually asking for these things. So this, since you brought that up, we can just talk about that. So the medical word is hyposmia, which is a reduced sense of smell. So a lot of patients with
the
Parkinson's
smell
have that.
Okay.
Yeah. So that's one. Not everybody has it, but if you ask them, there's other ways you can test it with smell test kits, but they're not affordable on a regular basis. But in general, if you ask them, but it's also difficult. And now with COVID, a lot of them have
Correct.
changes, or they're the chronic smoker, so they don't have a
Very
sense
true,
of
they
smell.
don't.
So you can't rely on that. But it can support the diagnosis. And then constipation, most people have. Some people don't, but most people do.
True.
And then there's another condition called REM behavior disorder, RBD. That is, again, not everybody has it. But if you develop that, so what is that? It's a sleep disorder where people tend to have violent dreams. So typically when we're asleep, in the REM phase, which is the rapid eye movement sleep, which is your deep sleep, our bodies have a mechanism to kind of paralyze us because you basically don't want to jump around when you have a bad dream. But if that fails, that's what you're doing. You're having these violent dreams of being attacked by an animal or someone chasing after you, and you are like flailing your arms or legs, and you typically end up, injuring your
Correct.
partner sometimes, falling out of bed. And a lot of patients remember the dreams.
Yes.
So this is a very telling symptom. Like you may not have Parkinson's symptoms when you start having RBD, but it can sort of predict that. There's no clear timeline as to when you can get it. Sometimes it can be more than 10 years or even longer.
The reason she's saying all that, I really appreciate why she's saying that, is they, even if they do raise this symptom, you should raise it with the right doctor.
Correct.
Because if they say to an ENT surgeon,
True.
by the way, if they go for some other problem or a dermatologist, anybody else, see, in their world it doesn't exist.
Correct.
You know, and sometimes they may say, oh, let's see for some time. And you know, that's how it is. Because
Or they may
it's
even
not,
send them to a psychiatrist, maybe.
whatever. What normally happens is, because it's not like somebody's falling off, it's a burning
true,
problem
true.
and things like, it tends to be forgotten. I went to a doctor, he said okay, and things
Yeah.
like that. Which doctor said okay is also an important thing for
Correct,
us. So,
correct.
you know, the message is even to our other colleagues who are not neurospecialists, for them to understand that if they don't know what the patient is complaining, it may be such a mundane symptom or such a simple benign stuff, they should not, you know, just brush it off and they say, I think you should see so and so. So that's a message that I think I really appreciate that she's saying that, because that I think is a big difference. Because very, very rarely the people come to us directly. They're all
Correct.
referrals.
Yeah.
So somebody has to refer them to us with this symptom. Other than many times they take many years to show up in front of us. You know, that is the tragedy of the process.
A lot of times, and the neurologist is usually not the first person that sees that patient because, you know, it's so random. It doesn't happen every day. It could, but it's not typical. And then, like I said, it could be years before someone has an episode, and then 10 years later they have Parkinson's. So, and if the patient is the only person who comes in, a lot of times they don't give you that history because they don't know what they're doing in their sleep. So it's usually the partner who gives us that information. So it's not a prerequisite, but if you have these symptoms, you know, constellation of symptoms, you're leaning more towards a Parkinson type of a syndrome.
Correct.
So I guess what we're trying to help our viewers understand is so many things can go into, you know, the non-motor, you know, these symptoms. And while we are talking about that, the other big thing with non-motor symptoms is mood changes, depression and anxiety. Again, these are not emphasized, you know, a lot of times, and things happen in your life and you attribute, you know, something happened, you lost your job, you lost a loved one, you know, you're depressed, you know, you think, okay, maybe it's that, it's a passing phase, it'll go away. But a lot of times, these things precede a diagnosis of Parkinson's by many, many years. So it's important to be, you can't, you know, if you got a diagnosis of depression in your 60s, you're not going to think you're going to get Parkinson's. But when you predate and you ask these questions, then you start to put the picture together and you think that, okay, this is all probably part of the same problem. It was just brewing and now you have a full-fledged condition.
So two things I want to add. One is, like she said, I don't want the viewers to get, you know, paranoid and obsessed, become an OCD. That, oh my God, so many symptoms. And why are we going making their notes and keeping every day looking out, putting on a piece of paper and saying, do I have this? Do I have this? You know, sometimes it can happen.
Oh, absolutely.
You know, so that's not the goal of this exercise.
And not everybody has everything.
Yes. So the goal of this exercise is to make sure that it's not a symptom. It's not just tremor equals Parkinson's disease and be done with it. There's a constellation of symptoms which come in different ways in different, you know, phases. Just to be aware of that, and you know, to know that, you know, to get this basket of symptoms, and as you grow older, good to know forewarned is forearmed, as what we say. That's what we want to do. That's the first
to take
thing.
attention to.
Yes. The second thing I just want to add to that, what she said about the autonomic dysfunction, about the blood pressure changes. That's a very common thing we see even as neurosurgeons. You know, they walk into our OPD saying that I'm having giddiness.
Okay.
You know, that's the commonest thing that come with. And then when you ask him the giddiness, the history is not so classical. And then when you actually probe a little deeper, then it's more postural. Now, postural giddiness is also known, vertigo is also known to happen. But then you have to have a high level of clinical suspicion as you grow older. Diabetics or Parkinson's, where it's called dysautonomia. And the simplest thing to do, which is takes like 5 minutes, is just ask your nurse to check the lying down, sitting, standing blood pressure. That's so magical sometimes. And you don't have to send them for a scan. Nothing is free. So, but that action many doctors don't do. for many months. They're coming to me from physicians, and checking BP is basically a physician's job, not a neurosurgeon's job.
Correct.
But it just doesn't happen because what the brain does not know, the eyes can't see.
Cannot see. Yeah.
And that's
True.
the key that we want to communicate. And now I think with the digital BP apparatus, everybody has it at home. Many people,
Correct.
they might as well check it themselves to know what's going on.
True.
So I think these are two things that I wanted to say.
And I want to
Nice.
just add to that, and you're right. I mean, when we look at these symptoms, right, because there can be so many, like I said, the sense of smell. A chronic smoker who hasn't had a sense of smell
Correct.
for 30 years, you can't attribute that to one disease. And diabetes is a very common thing we encounter. They have so many issues. So you always have to have, you want to rule out, common things are common.
True.
You want to make sure especially, it's quite common for people to have comorbidities. Someone who's had high blood pressure for a long time, they have very poor control of blood pressure too. So it can be any of these things. So when you want to give a diagnosis like that, you want to make sure you've checked all those
Yes.
things and make
Correct.
sure it's not like, in the elderly male patient, urinary dysfunction is very common. So you want to make sure they have their prostate checked, and that's not the reason they're having urinary dysfunction versus it's Parkinson's. So you have to know your patient well.
Correct.
Yeah.
Yeah. So before we go into management, like I was talking earlier, do you want to talk a little about the motto we put up here?
Treat the patient, not the disease.
Why
Sort
are you
of-
saying that?
Just leaning in on what I just said, like let me give you an example. Say a 70-year-old, male patient walks in, and they come in with a tremor. He's shuffling. I see him through the door. I kind of have a sense. Okay, then I ask him, okay, what are you here for? And they were like, my children wanted me to see you because I have this tremor. So then I asked them, okay, how long has it been? He says, I've had it for a month. And then he says, it doesn't bother me. My children want me. They're worried, so I'm here. And he looks kind of sullen, and there's something about him. And then I ask, get more history, and then it seems like maybe he lost his spouse, 2 weeks prior to when the tremor began. So he tells me he's obviously grieving, he's depressed, he's dealing with a lot of things at home. And then, I listen to that, I get all the history, I do the exam. At the end of it, I've kind of determined, the tremor, the way he walks, all the exam, that, okay, he's got some Parkinsonian thing going on. And then there's two ways I can deal with it now, right? The tremor is obvious. I can see it right there. It's pretty, So then I can offer to treat him, symptomatically, because I have a fair sense that maybe this is a Parkinsonian syndrome. So let's try some medication. That's one way to do it. The other approach would be, which I would prefer, is, when you listen to the patient, what did he say? He said he's here because his kids want him to come see a doctor. There's a tremor, everybody sees it. He's not bothered by it, right? There's another aspect to what's going on. He lost his spouse. He's depressed, he's grieving. So that, to him, is a bigger problem right now
Correct.
than just doling out medication and saying, okay, here it is. So what should I do in that case? Ask him if he has support. So he says he has children. So does he feel comfortable talking to his children about, how he's feeling?
Right.
A lot of times you get elderly patients who get a response saying, I don't want to bother them. They have their own things to do. I don't want to tell them. So, okay. So if you don't want to tell them, then would you consider speaking to a therapist, a grief counselor, things like that,
Correct.
where he can
True.
unburden and discuss, because clearly he's distressed. And sometimes those are situations where you actually see these disorders come out.
Right.
Because he's anxious, that's when you see these things come
Yeah,
out.
he
So
gets
it's not that he
unmasked.
developed Parkinson's all of a
Correct.
sudden. It's just unmasked by all these things.
Correct.
And another, so there's two approaches to this, right? I mean, if you think about the first approach, I gave him a medication for my best clinical suspicion. There's nothing wrong with that.
Correct.
But the second
Something
approach,
beyond that.
Yes, the second approach, you're looking at the patient as a whole. It's not just that tremor that I'm bothered, because he's, there's nothing wrong with that. But is that what he needs at that moment? Probably not. So you have to understand, your patient. You have to spend some time, be a good listener. Like, empathy is a very important quality. You need to understand,
True.
what is that person going through right now.
Absolutely.
What I want to say, add to that is, as doctors, we are fundamentally healers.
Correct.
We are not just giving a medicine and trying to fix a problem. I think that's where it's got missed so many times in the current practice. of transactional medicine.
Especially if you're in a hurry, there are patients lined up, so you want to finish.
And in
one after
medical
the
school,
other.
that's what is emphasized, that we learn to treat the disease, we learn to treat the
Correct.
condition. You have something, what do you do for it? What's the management,
I agree.
right?
Somehow, I think luckily some of us have gone beyond that. And I think that's the single biggest thing you have to drive home to all this younger generation of people, whoever it is there, that you have to be a good human being first before you become a doctor or anybody else. Because they come looking for, it's more than just, physical whatever support that is there. And sometimes I've seen just putting a hand on their shoulder. Sometimes I sit on a table next to them and put my hand on their shoulder and talk to them. Amazing how that energy is, just incredible.
True.
Sometimes I ruffle their hair, I do this on their cheek.
Correct.
Then I say, if you don't do this, I'll do this to them. Small things, make them
Very
feel
true.
that there's somebody who's trying to discipline them, somebody who's trying to get them, to look at something.
Somebody who's really concerned about something not just pertaining the disease, but beyond the disease also.
No, it happens because many times the patients come back to me and say, doc, if I come and talk to you, I feel 50% better.
Exactly.
So please come, we'll have a cup of coffee and go. So fundamentally, I'm here to treat patients.
True.
If I don't have time for those patients, then I
Absolutely.
should not be in practice. Nothing is more important according to me. You do anything else, I'm not saying no. But if you are a clinician, your damn business is to take care of those patients who come. Sometimes the consult may do in 15 minutes, sometimes it may take an hour.
I think this is a message I think we are trying to give across to the younger medical practitioners who are, life has moved, with a fast forward button nowadays. So everything moves fast. So I think younger generation is really moving much, much faster than what we probably did. So I think it's a good piece of advice if they want to take it. I think
I don't know.
makes
See,
a
I'm
lot
not
of sense.
saying that I am right, somebody is wrong.
It's
I-
not
No,
right
and
or
and
wrong.
everyone's
No.
approach is different. medicine
Yes.
is an art, so I'm not saying that
Absolutely.
just the way absolutely not.
I don't know, but what eventually they should be happy.
True.
What exactly what does that patient, and if the patient, after I say that, I want you to send you to a counselor, and if they say I feel okay, then okay. Or
Exactly.
if they prefer, if he says, okay, I'll take the medication, okay, then what? You offer it and you ask them what they want to do, right? And the other thing is, no two patients are alike. Parkinson's
Exactly.
disease is, you have a set of symptoms, but I'm sure you can all agree that there are no two patients who are the same.
Absolutely.
Forget
So
Parkinson's,
it's
even
really a very tailored approach, And sometimes the first thing you offered probably doesn't work well enough like you thought.
Yeah.
Like, the example we were talking about, say this person with Parkinson's has got diabetes for about 10 years, not very well managed. So now they're already having autonomic dysfunction. So if I start them on dopamine therapy, there's quite a good chance that their blood pressure will drop, So I have to think of all those things. I can't just focus on my disease and say, I don't care about the rest of it, go see your doctor.
I agree.
I have to put all of that in perspective. I may not have all the answers that day,
True.
but sometimes they don't know some medicines they're taking. And if I'm concerned that maybe there's going to be an interaction with that, I have to wait. I have to wait for them to get back and see, okay, if what I'm offering, is it wholesome to the patient? Not, I shouldn't be focused on just my thing.
Absolutely.
Because
Well said.
the patient is made up of many different parts, right?
Got it.
Exactly.
So you have a motto put behind you. So do you want to talk about that?
Yeah. See, we already addressed that subtly about movement problems being the problem in movement disorders. So whatever I do, I offer as surgery is with the attempt to make their movement better. If they're moving too much, I have to make it less. If they're moving abnormally, I have to make it less, appropriate. Moving less, I have to see if I can make it better. That's one aspect as far as movement is concerned. And obviously, in this whole process of, functional neuroscience I keep talking about, which is neuromodulation with advanced neuro rehabilitation seamlessly, fused together, it makes them live better. Like we have the statement that says that medicine adds life to years, but, rehabilitation adds medicine adds years to life. But rehabilitation adds life to years. I think the quality of life is something that even in India, because we are chronically short of hospital beds and doctors and everything else, the whole focus is on acute care and saving life.
Yep.
And very few people are looking at quality of life. They don't have time. I mean, I can't blame it.
Or
like,
they don't know the
Yeah.
importance
No,
of
even
that.
if they know, I think sometimes they run out of time. So okay,
They
next,
can't,
okay,
yeah.
next, okay, next. They
So
just
that's so I
move on.
always keep saying that I'm one of the few surgeons who's moved from saving life to also looking at quality of life, right or wrong, good or bad. That's the way it is. Somebody has to do this, and at time has come for us. I think our patients deserve much beyond that.
True.
Eventually, we have to figure out a way of mass rolling this whole process.
Absolutely.
But it's a small start that we have made to see how to make things better.
Correct. So now do you want to move on to how do you manage these patients? Now that you have done your diagnosis, what do you do with them? And when do you really think you would need a surgeon's intervention with your...
Once you identified, okay, you don't have, like I said, we don't have red flags yet. We're thinking this is most likely Parkinson's. As a start, you can start dopamine therapy on most of these patients because that's the chemical that's lacking, or not lacking, well, reduced. And that's what affects all these movements. So you can start with that, and generally Parkinson's patients respond well. So assuming, say, a hypothetical patient, they've been on medication for 2 years. Now, there are many complications of, let's remember that Parkinson's is a progressive condition. So what works well today may not be good for the next 2 years.
True.
So 2 years is an arbitrary timeline. But, say now they have, and there's so many intricacies in even administering this medication, where after you take it, there's a certain time when the medicine effect kicks in.
Correct.
And then there's a certain time where it lasts, and then it goes down. And then, so in our terms, we use this as on and off times. So the on times are when the medication is working, the patient feels great, they're able to move, they can talk, their voice is great, all these things. Then they have an off period where the medication effect wears off, and some patients can transition. They're okay, they don't really feel a dramatic change. There are some who it's like night and day.
Right.
These are the ones that struggle because those fluctuations can happen. Initially, for some people, they are predictable, like your medicine's lasting you 5 hours. Then when your next dose is coming. They're okay for the next 30 minutes maybe, but then they need their medication. There are some who are so dramatically different when they have no medication. So when you have patients like that, so maybe I can just talk about assuming that I'm thinking about deep brain stimulation, like a surgical option for my patient. So what are the things I'm looking at? If I have a patient who has a really bad tremor predominant Parkinson's, whom, we've tried all the, the medications we tried, pretty high doses, optimized them on medication. It's still very disabling. Then this is a patient I'm thinking, okay, they might benefit from surgery. And then, or if they have a lot of these fluctuations. So I'm doing the best I can with all the medications. They're needing too many medications, like on and off and fluctuations. So their day doesn't go well. Quality of life. That's what we're talking about. It's an absolute mess. Their day is so that's a patient I'm thinking, okay, we need to smooth things out for them. So that's another patient. Or there are these abnormal movements called dyskinesias. So they are sort of a combination of Parkinson progression as well as treatment induced. The funny thing about this is those movements happen when the patient feels best. So the medication is working, they feel great, but these movements are uncontrolled. So then, and dyskinesias can happen anywhere. It can happen in your head, in your hand, in your legs. Sometimes it can be disabling. Like if it's in the legs predominantly, it can cause them to fall.
Right.
So then, they have they feel good, but then they're disabled by this. So then that's another patient I would think, okay, I think they'll benefit from surgery. And finding the right patient is very, very important. So just as Dr. Sharan was elaborating, who are coming back to cognition. So these are sort of the people I would think, okay, if I need some more help. Or if they have high dose medications and they cannot tolerate the side effects, like dopamine sometimes can cause such severe nausea, some people just cannot take it. Or, like they're diabetic, they can't take high doses, they have other issues. So then you're thinking you need some extra help. So the thing to remember is, when we talk about deep brain stimulation, so I'll just brief about that and you can probably talk about other surgeries. It works as long as the medication's working. And it works better for these symptoms: tremor, slowness of movement, stiffness. If the Parkinson patient has more of gait and balance problems, it's usually not advised. The surgery is not advised. Or if they have a lot of cognitive problems. Now, cognition in Parkinson's can be affected. It doesn't come on very early unless they have other reasons to have cognitive issues. Age is one thing, of course, and if they have other reasons to have cognitive impairment, you can see them early on. But cognition has to be fairly good for this. And then, of course, other issues like, if they have cardiac things and things that they cannot undergo, those are other patient-related factors. The other thing is mood. So if they have psychiatric issues that are not well controlled, like say this person has very bad depression, and that's the only thing keeping me from referring them to a surgeon, then I'll have to wait to see that their depression is optimized. It's not a no-no, but you just want to make sure that they are optimized. So then I'm thinking, okay, this person is a good candidate. And in order to determine whether the medicine's working, we typically look for like a 30% improvement. So that's an arbitrary number, sort of a cutoff. So I have to examine the patient in the off state, meaning I'll see them first thing in the morning with their medicines completely off to see what they look like. And then I get a score. And then I have them take the medication in the clinic. Then I wait a little bit, assuming it takes however long they need for the medication to kick in. That score difference. So if it's more than 30%, or it shows that the medicine works when it works, then this person is a good candidate. If they don't show any improvement or very little improvement, the chances that deep brain stimulation will work is probably not great, but it's not an absolute contraindication to not do the surgery. So then there's another team that we work with. First the doctor determines, okay, this is a good candidate. Then you have to meet with the psychiatrist to determine, cognition and mood and all of that. And then we talk to the surgeon to determine, okay, what's the best part of the brain to intervene. That is again based on usually their symptoms. If it's tremor related, we like to place the electrodes. We'll talk more about that, or maybe you can, in a certain certain parts of the brain. So we determine the symptom and the side, which side is worse. It's the opposite. So if the left hand tremor, then you're trying to do it on the right side of the brain. So all of this background work has to happen, all of this, to determine that the patient, and then you have to set expectations. So what happens once the person undergoes this procedure? So just to keep it simple, electrodes are placed in the brain, and then wires connected to a device like a pacemaker in your chest. And it's probably, we have the patient stay for 24 hours just to make sure there's no complications. And then there is something called programming. So then I, as a movement disorder doctor, will have to set the parameters for optimal control of tremors. So the stimulation is what we call it. Yeah. And sometimes it takes several sittings. It never usually happens with just one. Even after I program them for the first time, I have to have the patient wait to see how they're doing.
Right.
Because do I need to reduce their medication? Because now the DBS is working. Correct. Usually, you can't get them off all medication. I could probably reduce a good amount. And then I have to determine, okay, do they feel good, with what I did?
I think this is one question a lot of people will have, that if I undergo a surgery, then that means to say I am off medication. People have this.
It's usually, you rarely have someone who doesn't take any medication at all, but you can reduce the dose and the,
some baseline medication.
You can, yeah. That's the goal. So that's what you want. All of us are different. Sometimes you don't get that.
Nobody wants magic.
Right.
So, but that's what you have to understand. And then it's an ongoing process. Just because I've programmed them once doesn't mean, it's not a one and done thing, right? Yeah. Because the disease progresses. And every day your symptoms change, right? Every day it's a different thing. But for the most part, they'll be okay. But then sometimes they have to come back for readjustments. And usually the patient is also given a device, like a remote control. Yeah. So we can set the parameters. Like when I was programming them, if I saw that if the stimulation was set at, say, 3, I saw that their walking was affected, then I'm going to make sure that their setting is lesser, to maybe to 2.5, so that they don't do that and then they end up.
Correct.
So, just those are like the intricate parts of that. But it's it is definitely, I think, something that helps quality of life, because the patient went from having all these issues and now, they have some benefit. The day-to-day life is somewhat better. But you have, like I said, setting the expectation is the biggest thing. Because
Absolutely.
then you don't want a disappointed patient saying, you told me this is going to happen. And the other side of which you're not talking about, which you can probably talk about, is complications from the procedure itself. I mean, we've had patients who ended up with hemorrhages because it's an invasive procedure. And then sometimes that renders them worse than where they were. So those are all, you do your best, right? But you can't control for everything.
So, for the sake of our global viewers, if I can ask this question to both of you, that if we take typical Parkinson's disease, they can be medically managed, some of the patients, and only some of the patients who qualify to get the benefit of the surgery can undergo a surgery and get the benefit, whether it is lesioning or whether it is DBS. Is that right?
Yes.
Yeah.
Yeah.
And a lot of times, even though the patient is a candidate, they don't want any surgery.
Yeah. I mean, that is a choice left
we
to them.
Yeah.
Yeah.
So, yeah, I mean, the first job for me is to pick the right patient. And
Right.
after that, all of this comes in
Correct.
place. Yeah.
Right. Now that between the two of you, you have decided that you have picked the right patient and you do have to do the intervention. How do you go about with it?
So it's like, as much as she crosses the line and becomes a little surgically oriented to make sure that she's come across that line, I also need to go to the other side to make sure that, double check whether everything is in place. That's what I would like to do. So just to add to what she said about Parkinson's disease itself, so I always tell my patients there are 3 types of Parkinson's disease. One is a tremor predominant, and what is interesting in tremor predominant Parkinson's disease is it remains one side for a long time. It's very interesting. Some of them 10 years, 12 years is predominantly one side.
Okay.
Sometimes they have a little bit on the other side, but it's amazing how it's predominantly one side. That's interesting data. Second one is that, there's the other extreme where they don't have any tremors, but they have slowness, what you call bradykinesia, rigidity, and things like that. So that's the other extreme. And there's a mixed type where you have a combination of both.
Right.
This is roughly 1/3, 1/3, 1/3 that is there. So I need to also first see what's going on. The second thing, what she said about she wants to see them in the off phase and all that.
Correct.
So here formally we do, as a surgeon, as a part of my pre-surgical evaluation, I do something called the levodopa challenge test. It's called the LCT. So we tell the patient to go to a rehab team, and the rehab team then runs this test, gives them instructions to come 12 hours, empty stomach. I mean, not more than empty stomach is off the drug of Syndopa, the levodopa. Then we get an off-phase evaluation done, a complete evaluation.
So what are you trying to figure out in that?
So, okay, it's a good question. So what I'll be trying to see is, like she said, the best on result is the best surgery result.
Right.
So I want to know what the best on result is, first of all, to myself. So then I know how to set expectations for the family. So I need to see the videos, because then everybody said, I said this, you said this, I said this, because there's no test for me, like a blood test to show a report or a scan to show this. These are all purely clinical. So with the clinical, it takes about, quite some time to do. So our rehab team takes care of this, who's oriented to movement disorders. They do this work. They do the UPDRS scales, and then based on that, they capture videos.
So for the sake of our viewers, would you do this in an outpatient basis? Would you do this in an inpatient setup? Where would you generally do this LCT?
Commonly, it's done outpatient. Okay, so but there are some patients, very rarely, who need inpatient for levodopa challenge. The only time they need this is when they're so bad in off phase that they can't even move. They said, sir, we can't bring them and come. They literally, you have to carry them in. If they're that bad, then I say put him in. So it's easy for us to assess, to see what's going on. And, some of the patients are like, like these drug addicts, the moment they're going off, they swallow the medicine by themselves. It's crazy. Some of them are popping
dopamine
in extra pills. So
dysregulation.
you need to hide the medicines, and they're fighting going on. And literally it's like that. So we had a Nepali patient who was like fighting with his wife for this. It's crazy what was happening, He would crawl on the ground and all of those things, it was crazy.
Have you encountered those?
Dopamine dysregulation, I mean, you do
it's
have,
crazy.
and it's commoner in younger patients.
Yeah, he was
because
young,
they are so aware of the change in their symptoms that they just don't want to. I mean, you can't,
I'm sure.
given that
empathize with
situation,
them. We have to empathize with them, so we have to find the answer to that. So first is I obviously get a detail off score. So you get the off score and the off videos. And then normally what we do, so we give a supranormal dose of the medicine,
Okay.
a little more than what they normally take. So to see that if I get a maximum dose, what happens?
So if you give a supranormal dose, is there a chance that they may develop something like dyskinesia?
Yes or no to that. Yes or no to that. So that's what we are trying. First of all, we've got a history whether he already has a history of dyskinesia.
Okay.
If he has disabling dyskinesia, then we will not give the
You don't
supranormal
give
dose because we don't want to kick it in further.
Correct.
But if he doesn't have, and then we need some people say, oh, the medicine is not helping me. We want to know what is really going on. I'll tell you a story about many stories, but one I will tell you. So we capture that on face. So you have to wait for X amount of time before he actually feels it's on. Patient will say, I feel the best, and then we reassess it, and then we see what is the percentage of dystonia. Like she said, is it at least 30%? Now, like she also said that this is not like, cast in gold at the end of the day. Because sometimes in tremor-predominant Parkinson's disease, the syndopa doesn't work very well, levodopa.
Yep.
So then what happens is the scores can still be, then the tremor score is the same, other scores or whatever, and especially if they don't have the other scores, symptoms at all, then the scores don't change much.
Correct.
So we have to keep that in mind. So what interestingly happens is we see, so that helps me to set an expectation, at least in the mixed type and the tremor non-predominant Parkinson's disease. Now, we had a patient recently. He's a doctor's father. Okay, she's a cardiac surgeon. She's currently training in New Zealand. She's based out of Mumbai. He lives in Bangalore. This guy, somebody referred to me, tremor predominant Parkinson's, one side, 67-year-old guy, very active otherwise, no cognition issues, came to me for surgery. One hospitalist told him DBS, and somebody told that I don't do DBS. Apart from doing that, I also do the burning, lesioning surgery. So he wanted to check that out. So he came to me. He said, I want surgery. Or whatever it is, he came, and I was trying to explain to him, there's no device if you don't want. And it's only one side. Then I told him, you need a levodopa challenge. Quite an educated, well-informed guy. I said, you want a levodopa? He said, no, I've done a levodopa challenge test already somewhere, the previous hospital. So where's the report? He didn't have a report.
Okay.
He didn't have a formal report, just mentioned some. I said, I don't like to go by this. I want a formal assessment. So I had a talk with his daughter, and we sort of went back and forth. And once everything was done, we called him for this. So he came here, we did the levodopa challenge test, and with the supranormal dose, his tremor, everything went away 100%.
Okay.
Nothing. He had no symptoms.
What does that mean?
I'll tell you what it means. So what happened then? The assessor dug further. Now what has happened is he and his wife are living alone. The kids are out. 2 kids are out. Both of them are doctors. Wife died about a year ago.
Oh.
He's got depressed. He's living alone. So he's medicating when he wants. He's hypomedicating himself. He's not doing enough.
Exactly.
Okay.
So now we had to tell him, sir, you take your medicine properly. You may not need surgery. He was disappointed
doesn't need
because so I had to convince him that I'll give you some time.
Don't do surgery.
No, let's try it for some time. See if you're not a candidate for surgery. So that's one extreme aspect, as I say.
Yep.
So couple of things like she says. So this is one aspect. So before that, the history we're taking is the on and off. We call it the on and off fluctuations, which the on time keeps on coming shorter and shorter and shorter, and the dosing becomes more and more frequent.
Yeah.
And then the on dyskinesia comes in. That's number 2. So they're going like this all the time, they're restless and things like that, but they still prefer that to standing stiff like this. So many factors are going on. But to cut the long story short, the surgery helps only managing the motor symptoms of Parkinson's. That is the first message I have to tell them. So once I
So
tell
it
them,
basically doesn't cure the disease.
nothing cures the disease. The disease, you're going to die with
This
the
is for the
disease.
sake of our viewers.
No, they're going to die with the disease.
Yes.
I think the quality of life is what we're looking at.
Right.
We are
day
trying
to
to
day.
see how much of which symptom is causing what problem to him, and how much can I impact that symptom, and how much that symptom will impact his quality of his life in his situation, societal situation, things like that. So coming to the decision making on surgery. So once we agree with all of these things, and he says he seems to be a candidate for surgery. So that's the decision we have all made together. Whether he'll undergo the surgery is different. Then what am I offering here? Now this man, he has the money, this same man for one side. But the issue is he has got only one side.
Right.
So normally one side you don't do DBS because you very rarely they do, at least maybe there they do, here we don't do because 2 sides you do, it's so expensive and things like that. Secondly, living alone, managing the device becomes such a big issue for them to do all of
absolutely.
this because there's no caregiver. So I said I also do that one side lesioning, which I do this one. So it may be an easier plan, 67-year-old guy, predominantly tremor, predominant Parkinson's. He doesn't have very little of bradykinesia, rigidity, and things like that. So I said, why not? So I gave him both the options. You have this, you have that, you can still do that. And the targets are different, so you can still undergo DBS later if necessary. So then we went back and forth. So, but I can fix this. You know, this tremor like this, we've had patients, we've stopped this, and then they're doing well for many years after that. So that's one aspect of it. And if it is bilateral and if they have no money, then obviously DBS is expensive, and if they don't have insurance, they don't pay for it, then we have to give them some solutions. At least in resource constrained countries like ours, where you can't say, you know, if you don't have money for DBS, go and suffer. I can't say that. You know, it's very unfair for me to say that. So I have to come up with a solution which is more affordable. And this surgery that we do called lesioning or burning a circuit inside the brain is 5 times cheaper. And very little of follow-up is required, especially if they come from places where there's no follow-up, no neurologists do a programming, they don't understand. The programmer is 11 lakhs.
Oh,
Wow.
okay.
Yeah, so somebody has to own the programmer. Now, others, the programmer has to go from here to there, there to there, there. I mean, it's all it's crazy.
And they have to have a movement disorder neurologist who will do the programming
so
there.
it's like that. So, you know, and you can't wait for days, because if you're struggling, then somebody has to do it immediately, whatever it is. So you have to look at so many factors. After he decides that he's a candidate for surgery, you have to look at the possible post-op needs of the patient and see whether his social economic situation allows that thing to happen at all.
And then charging and rechargeable devices.
So many things.
There's so many aspects.
So many things. So you
maintaining it is quite
they
a
have no
task.
idea. They have no idea about this. They have no idea what they're getting into. So it's our responsibility as a surgeon
to educate
think
them.
to think through all of that, take all this information from him and create a possible, you know, plan, post-operative recovery plan, and then ask them, see, listen, this is going to happen. Can you afford to do this, or can you, you know, logistically do all of this and things like that? And then obviously, you know, the money may be willing, but the logistics may not be willing. Or his general condition may not be so good that he will tolerate a long surgery and things like that. There's so many different ways of looking at it. So considering all of that, so I do different options. So before I come back to DBS, I'll do the lesioning work, you know, what I do, the burning surgery, because that is, you know, more appropriate in resource constrained country like ours. So what we choose them is, you know, we say, okay, which is the, you know, the side that is bothering you? Obviously the side that is worse. So they want that to be fixed first. So then we decide the opposite side of the brain has to be fixed. Now the decision making on, see, each location of the, you know, the God has created this, you know, it is the brain amazing.
Microelectrode recovery.
Yeah,
It's
I always say that the human body is designed by God for surgeons. There's so much that we can do. It's incredible what is possible. So it's predominant tremors, for example. Then the target is a nucleus in the motor thalamus called the VIM, or the ventralis intermedius nucleus of thalamus. That's what is possible, and we can fix that. And it's quite dramatic. The moment I hit that, the tremor stops if I'm on target. So that's one aspect of that. Suppose the patient has a combination of the mixed type of tremor with rigidity. Then there's another nucleus called the GPI, or the globus pallidus interna. So that the posterior ventral part of globus pallidus is what we target for that. That's called the PVP, and that works very well. And that's a great target, especially when they have the drug-induced dyskinesia. You know, it just goes away. So that is something I've actually promised my patient, that your dyskinesia will go away 100%. You know, and the on-off goes away. They just get managed much better. But the medicines will continue, but managing these things get much better.
Easier.
And then we also have another target called the PTT, the palliothalamic tract. So these are the few things that we do. And we can do staged bilateral lesioning, which is what I'm one of the few people in India doing staged bilateral lesioning, which is all I can do, which is also what we can do. Otherwise, you do the DBS. The DBS is the commonest target in deep brain stimulation surgery. Is the STN, which is the subthalamic nucleus. So for some reason, the GPI is not a very liked target by most people. I don't know why. So I actually tell everybody that it's like the HIV virus and the hepatitis B virus.
Glamorous one.
The hepatitis B is 500 times more virulent than the HIV, but the HIV is the most sexy virus, you know. So they move, you know, it's like that. HIV, because all the film actors get it and all of those things get it, versus the HIV, it seems to be more the poorer things like. That's how I look at STN and GPI. I love the GPI nucleus. It's such a fantastic nucleus. It's such a stable nucleus. You can do it. And honestly, when she was talking about the psychiatry issues,
Mm.
now that's where I want to differ with her and say, not when I say differ, see the indication because she's thinking STN, she is thinking psychiatry.
Mm.
Now, because if people have psychiatric problems, the STN target worsens it.
Okay.
It's the opposite of GPI.
prefer
Okay.
not to that.
Yeah, but then that's when the GPI gets selected.
Oh.
That's what I'm saying.
So
that
you mean to say if you're doing GPI, then you don't have to worry about the
Yeah,
psychiatric
I don't.
issues?
For the most part,
Yeah.
yeah.
Okay.
But I
We
mean,
don't.
it depends
But
on
yeah,
how
I'm
bad
not
it
saying
is.
yeah,
But
but
yeah.
what I'm
But
saying is,
STN for
it
sure,
is,
there is.
in the sense I would not do the surgery
Mm.
because the psychiatric problems.
Got it.
I would do a different target.
Mm.
So that's where the targeting becomes so, choice of targets becomes so
Right.
important. On one side, the motor symptoms, other side, the patient's other symptoms, and see what's the most optimal, spot to be, where I maximize the results, I minimize the side effects of what's
Right.
going on.
I think this
So-
kind of information is a big treasure for young medical people who are looking at this session.
And
right?
and it keeps. I mean, there's so many. They're trying to figure out so many more new targets now.
Yeah,
It's-
so
it's-
that's the more we are understanding these things, then that's the way the functional brain circuits become so important for us. That's why unless I actually pay attention to look at why I did what I did,
Okay.
then I can never go back and see, no, I thought something, I did something, did I get what I thought? So I have to go. So there's so much of energy spent on this, and I can't bill the patient for every of these activities that I do.
Correct.
So it's a lot of energy for the returns, which is not so much. So unless you're crazy and passionate about this work, it's not remunerative enough for people to really
True.
invest so much of their time on that. Because then after that, you have to handle the family, the patient, happening, not happening, and a lot of those things.
So, I mean, what is your, so say this patient, you did the VIM, and then what is the longest, like, how do you tell them that there is a chance that, do you ever see the tremor coming back, or, because it's a progressive disease. Like with DBS, I can tell them,
Right.
it is a progressive disease. So we can, we can keep changing, the stimulation settings. And now we have newer leads that are directional. So before it was like, if you're trying to make one thing better, you're making something else worse. It's changed so much. I mean, there's so many advancements in that. Like you can change the direction of each of the little contacts, and it's so much.
I agree.
It's progressed. So, but again, it is in some ways reversible. Complications are going to be there. But for instance, if someone doesn't want to deal with it anymore, I could turn the stimulation off, and we'll manage them with medications or however they want it to be. But sometimes, with surgeries like lesioning or focused ultrasound, that's another method we use, where ultrasound beams are concentrated on that part of the brain to treat tremor and things. Those are sort of considered permanent. So how do you explain that to your patients?
So thanks for bringing that up. It's a very uncomfortable topic for most people. So personally, the reason. So my question back to you is, if lesioning has been around for 60 years.
Okay.
Okay, and I call the current version of lesioning we're doing is lesioning version 3.0.
Okay.
Like you have software versions, we have
Right.
the surgical treatment version. I'll tell you what 1 and 2 are. But so it's 60 years. So it's time tested.
Right.
Now, if lesioning was so bad, why did some companies spend the money making a focused ultrasound, which is so expensive?
I know. I've heard about that.
Either he's mad or there's something going on. I mean, this is you have to ask yourself this
True.
question. And not only he has made it, people are buying it in US.
Yes.
In Canada, they're buying it, they're using it, people are going, all this is happening. So
Correct.
there must be something going on. There must be something right in what is going on there. So this permanent, non-permanent is market driven.
Okay.
This is my talk on it. People may feel bad about it, but you know how much the industry drives anything everywhere. We have the statement which we say, if you have a hammer in the hand, everything looks like a nail.
Correct.
Yeah.
You have vessel will stand. It's like that. So we do not know. The goalposts are changing so much.
Right.
So let me tell you a book I was reading in the year 2000. It was written by one of the world famous economists called the Professor Paul Zane-Pilzer.
I remember that.
And he wrote a book called The Wellness Revolution. And he writes in the book in one of the pages, he says, if the R&D of a pharmaceutical company discovers 2 drugs, one is a $10 drug which cures the cold forever, and second is a $1 drug that controls the symptoms of the cold only, guess which they will market? The $1 drug. Because this, I am not,
Which
there's nothing
is very
right or wrong on that.
obvious.
Right.
All I'm saying is, I am not working for the pharmaceutical industry. I am not working for the device industry. I am working to get my patients better. And that is a statement I can make anywhere. And I have no regrets. Even if people shoot me, I'm okay with it. But the truth is that if I think DBS is the right option for my patient, he doesn't have the money, I will raise the money.
Okay.
But if I think the lesioning is enough, like this old man who has money for DBS, I will convince him not to waste the money. With equal conviction. Because I know what is going on.
Right.
So it's like that. That's the first thing. So the
So basically, what
reversibility-
is good for the patient?
Yes, and then see, my experience with lesioning is about 7-8 years right now. The earliest Parkinson's I did was 8 years. She's still fine after 8 years with no tremors on that side. Okay, I have seen my professor who, when I was training under him, he had 20 years experience, and I have seen patients coming back who are doing well. So
the tremor has not returned for
not
most
enough,
of them.
not enough for them to
okay,
get worried
sure,
about
sure.
it. All right. So obviously, like that's why I'm repeating that case selection is critical.
Absolutely.
So, and because tremor predominant Parkinson's disease do not progress to bilaterality, and if there are 7-8 years tremor predominant and they're purely one side,
So you kind of sorted it out.
I mean, already we have sorted out PSP, we have sorted this, we have sorted out, we have sorted all of those things. That the other side is not coming.
I mean, I think eventually they do get symptoms on both
Yeah,
sides, but the one that was
asymmetry is
worse is
significant.
usually the worst.
The
yeah.
asymmetry is so significant.
yeah.
You know what I mean to
But
say?
I think 8 to 10 years is a very long
Even
Yeah,
I
and
say
think
that,
about
I-
their quality of life you gave them back
I
because
only
you
tell
helped the
them
tremor.
5
you know?
years quality of life.
True.
I don't promise. If you have good quality of life 5 years, be happy.
Yeah.
We'll take it in chunks of 5 years. Number one. Number two, what I have seen with even one side lesioning, there's a 30% benefit of symptoms on the other side.
Okay.
And enough data is showing that, not just from my data. Don't ask me why people don't know why it happened. That's happening. That's number two that is happening. So that's very interesting. So coming back to lesioning, I just want to give you a history of lesioning. So lesioning 1.0, what I call as 1.0. In fact, I gave this name versions
Okay.
1, 2, and 3 when I was in Japan. Lesioning 1.0 is the pre-CT scan era or the ventriculography era. When there was no scan available, they used to inject air into the ventricle
Yeah.
and then do some x-rays and look at it and do that. Imagine. At that time, they were getting results in Parkinson's disease. This is in the 1950s till 1967. So 1968, levodopa came in. The year I was born.
Okay.
So levodopa came in and then boom, the surgeries went down because levodopa started working.
Okay.
It's now, we just celebrated the 50 years of levodopa recently. And what's interesting is after levodopa, so many medicines have come. Still, levodopa is the best.
Yep.
It's very
Still sort of the gold standard.
That means that with all the R&D that's happening in pharmaceutical, it doesn't mean that you spend all the billions of dollars, you will always get a new molecule.
Correct.
It's much beyond that. Then it revived back somewhere in the 1990s because the levodopa side effects started kicking in and there was limitation of what was going on.
Right.
And then they realized that, I need to have little more armamentarium in what's going on. Somewhere in 1991, 92. And this version 1.0 was mastered and perfected by a neurosurgeon from Sweden called Professor Lars Lexell. And even today, his papers are seminal. Even today, those are the same target coordinates we use for that. It's amazing this man was able to define that in the pre-CT scan era. And, we are struggling to do it in the MRI era. And then the second thing came in, that's the version 2.0, which came in 91, 92. And his student, Professor Lars Leitinen, again from, Sweden, took it on, read his papers, met him, he was still alive at that time. And then started doing it back and produced the same results, maybe with more accuracy. So I called the version 2.0 CT MRI era. The CT and MRI had come, we had more, clearer brain images. We could see the structures better and things like that. And the version 3.0, what we do today, I call it the post-DBS era.
Okay.
We are now nearly 29 years from DBS coming in. DBS still has a lot of challenges. They have not mastered the technology. I'll tell you part of when you were saying about so many leads and all of those things. The critical thing, Maitreyi, in this is targeting.
Yep.
If you have lead in the wrong place,
Absolutely.
it doesn't matter you have the world's best technology of programming, it is useless.
Absolutely. Yeah, I agree.
And what is happening here is...
Or lead migrates sometimes,
Yes,
after
because,
surgery.
yes.
Yeah.
And because the industry people are overplaying this technology, surgeons are dropping their guard, which I think is unfair. You understand? Because we have to, like my professor says in Japan, a fool with a tool is still a fool. So when I was doing, there's a program called the Noble Art of Lesioning, which was running in Japan. I mean, in all over the world, the 4 senior neurosurgeons who came up with this forum to keep this art of lesioning alive. And one of those events happened in Boston, in Harvard, in USA. And there the head of the department was telling that global statistics are 20% of leads put surgically have to be surgically repositioned.
Oh.
20%.
Okay.
So that's a big number. And what worried me when I heard that was how many are not in position which are not being repositioned. So whether the result not coming in or the side effects coming in because of the wrong location. So that means it's not the technology that I'm against.
Right.
I'm driving the point home that the targeting cannot be suboptimal because the technology is better.
Correct.
Right.
That's what I'm hearing. And that I think should not happen because this brain is still an old-fashioned wired model.
Right.
Nothing is changed upstairs. If you do that, and the difference is in the lesioning, I have to be on target. I'm in, I'm out. If I'm off target, the game is over right there. So that's what makes us so much more, focused on what we are trying to do and things like that. So if we do that, that's why I'm very confident of what I will do with DBS, because I know I'll be on target. Because we are checking, constantly what's happening, fine-tuning what's going on. So if you do that, and to answer a question about, sometimes the DBS gets infected because many of them are comorbids like, diabetes.
Correct.
And you have to pull out the DBS. Then what do you do? Then you have a lesion. There are people lesioning through the DBS. Then why are they lesioning? Here's a question. So all I'm saying is, what am I driving the point home is, don't say reversible, unreversible. This, that. Both of them are complementary. They have their roles to play.
Correct.
And if I do lesioning, it doesn't mean I can't do DBS because
Correct.
the targets are different.
True.
It's just that at that particular point of time, for the patient situation, which is
What
a
was
right
the
strategy.
Best one.
If I keep that in mind, I think I will be serving the patient and the situation rather than serving the industry.
Absolutely.
And then affordability is what is a
That's
big,
what
is a big
you're
yeah.
taking
In
a particular
Indian
situation.
scenario.
You have the checklist and go through the checklist and say, I think this is what I think is best for you.
Correct.
But if you insist for me to do DBS, I will do DBS. But don't regret later, come back and tell me I'm struggling to manage it. But that's a problem.
Right.
So we have to they don't understand all these things. They're getting first time into all these things. They want the best.
So it's up to us to educate.
Yeah,
Absolutely, yeah. We have to
everybody
spend
wants
so
the
much
best.
time.
No?
Correct.
You anyway go, give me the best treatment, best medicine, best psychiatrist, best doctor. Everybody asks you the same question.
course.
Whatever that means.
Nothing wrong about it, I guess.
No,
That's why I say that. I mean, it might be the best treatment,
True.
but maybe not for you.
yeah, exactly. So that is what the counseling becomes critical.
True.
For us to make sure. And I always tell my patients, I have to first convince myself, and then only I can convince you.
True.
If I am not convinced, I will not convince you. Okay. I said, you can go and get it done anywhere. I will not do it. I have the conviction to say that. And I think that is something that we should have,
True.
as clinicians, to say that, we have, because the first oath I've taken is, if I can't do good, don't do harm.
Right.
So I have to be very clear about that.
Yeah.
I think, guys, the topic is becoming a little too hot now. So let's just talk about some before we go into a little more depth about other topics, other diseases which are there in movement disorders. Can we talk something about? I mean, the work is stressful on both ends. I understand that very well. How do you actually release that stress, relax? What do you guys do? I mean, you can go first if you want to.
I have to find the time first.
Okay, so how do you find time?
I mean, well, given the little time that I have, I think I like to spend it with people I love, family, friends. That's usually how I relieve my stress. I'd like to start reading books.
Okay.
So that's something I would like to
Okay.
do. But otherwise, where I live, it's there's a lot of nice outdoor places. Honestly, I think for me that's a big thing. Getting some fresh air, getting sunlight. Sometimes that's hard to come by. In the winter months, but honestly, that's really what I try to. It's hard sometimes. After a long day's work, and especially when mentally sometimes it's a struggle to switch off.
True.
Especially when I've seen a very difficult, not that the patient was being difficult. It's a complicated case. When I've given somebody a life-altering diagnosis, you can't just come home and switch off and say, okay, I'm done. My
Yeah.
job is done. It lingers on. That's a different challenge. I mean, as you've been more in the profession, you kind of learn.
Yeah.
But because when you're telling the patient, you
gonna die
can't
tomorrow,
get
yeah.
emotional, right?
True,
You have to keep
absolutely.
a straight face, and then you have to deal with the aftermath of giving the diagnosis.
Right.
And I think the mental stress of the job is very taxing. So far, okay.
Okay. So, do you have it organized like a periodic break, something like that? Or you just do it as and when you think it's needed?
As and when. I mean, I don't have the privilege of.
Okay. So, what about you?
So, one thing I did see, when I was in my final year neurosurgery, just a few months before exam, I asked myself the question, what's my future as a neurosurgeon? So, because there was nobody sitting and telling you this is how your career is going to be, you're going to go here, you're going there. And let me tell you the good news. Though we are very few neurosurgeons in this country, nobody comes to campus and recruits me. Like the IIMs and IITs where people get a package from Amazon and get a package from Infosys. We are not. Have you got any package anywhere coming and hunting for you? We have to go hunting for.
We have to, yeah.
So it's even the US is the same. So it's like that. That's the first thing. Anyway, so I was asking myself this question, and then at that time, I was working in one of the best corporate hospitals of India, in Bangalore, and under one of the two best neurosurgeons at the time who were at the peak of the practice, career-wise, money-wise, recognition-wise. So I told myself, if I get all the skills that they have, which may not happen, if I get all the breaks that they got, which may or may not happen, that's my best possible future. At least that's the future I could see. But what was critical is the next question I asked myself, do I like that future? I realized that they had become slave of that practice. They had gotten trapped in that practice. I said, I don't like that because I don't want to burn out. It's like burning the candle from both the ends. I love this profession. I want to be a neurosurgeon from 8th standard. And that was like sort of bothering me, which is right, which is not right, and things like that. And then I read an article in one of the, I don't know which journal, one of the good peer-reviewed journals, about divorce rates among doctors. And number one was neurosurgeons.
It's a reality, yeah.
Number one was neurosurgeons. I looked at it and said, I'm becoming a statistic. Another number here, I may be 51 or 52 or whatever it is, that number I'm going to go. Says, and already she was cribbing, saying that what's going on here, I don't see you, and all of those things. I said, oh my God, I'm becoming a statistic. I better watch myself what's going on. That's when I decided. That's the second thing that happened, all around the same time. Third, and 6 months before my exam, I developed a painless swelling in my neck. Okay, January of 1999. And by June of 99, it became very big. But painless, nothing. I'm running around like crazy, doing my calls, wrapping up things, my thesis, this, that. And my neighboring department OPD is ENT. So I would meet the ENT registrar in the corridor. He'll say, take this medicine. I just pop something, nothing happened. By June of 99, it was so big, I could see it in the mirror 5 feet. I said, something is going on. I went and showed somebody. They said, get a biopsy done. They stuck in a needle here, and it came FNAC, which came inconclusive. I said, no, that makes no sense. So I got a formal biopsy done. It turned out to be tuberculosis.
Wow.
Okay, no fever, no loss of weight, all blood tests normal, ESR normal, chest X-ray normal, ultrasound appointment normal. I realized that all of us have the TB bacteria inside our body by the 1 year in India, and the only reason it has flared up is because my immune system is down, and which I was not surprised because I was not sleeping properly. I was at the mercy of that canteen.
Just the demands of the job.
Our canteen had two very good dishes. I think every canteen will have that. It was called rubber vada and fighting chapati. So if you put that spoon in the vada and remove it, it just come back like this. And you not cut and the chapati, you have to literally fight with the chapati to get better. So I realized that I had become a statistic because of all of that. Then I started my antituberculous treatment, and not in 5 days after my antituberculosis treatment, two of my juniors had to go on leave for their exams. Now they went and applied for leave, and the chief said, Sharan has got tuberculosis. He may take leave. So if he's taking leave, you won't get leave. Now I didn't understand 2:1, first of all. I didn't know what that logic meant. They came and literally fell at my feet. They said, please, what to do? I saw their face. I said, go. On antituberculosis treatment, I did 36-hour calls every alternate day for the next 4 weeks. That's when I realized, in the hospital, they were looking for a donkey to work. Whether this donkey was dead or alive was irrelevant to them.
True.
That's when I realized I should take control of my own life. Because if I'm not worried about me and my family, who else would be interested?
It's not always easy.
Yeah,
I agree,
it
but
isn't.
it was difficult. But I had to do that. Because then I realized, I didn't expect to get tuberculosis. Let me be honest about it. And I said, shit, if I'm going to get out of this, what's going on? It was like that. So anyway, that's how it went. And that's when I decided that I will never do it. Once if I go into practice, I will never do an evening practice. Because evening practice is very common in India, where people sit in an outpatient from 6 o'clock to 10 o'clock. Everybody finish work and
Or
come.
even up to 12 o'clock sometimes.
Yeah. So that's a call that I took, that I said that family is as important as, taking this. That's why I've not burnt out. And that's one of the things I do. Apart from that, I love creation in neuroscience. So when I'm thinking about neuroscience and this one, I'm quite happy about what I do. Plus I take holidays. Do those things.
I think the other thing is like decision fatigue, when you're at work,
Yeah.
you're like constantly making
Correct,
decisions
yes.
for the
It's
patient.
demanding, right?
You're like, then you come home and it's like,
Shut off. It's like you're
don't ask
shut
me
down.
anything.
Yeah, shut down. Your
But it's
system shut down.
not fair to the family because
Exactly.
to
No,
balance
exactly.
that is
True.
so difficult.
No,
And
but
in
we have
today's
to fight
world,
it.
The
with
reason
the-
I asked you guys this question is, it's very inspiring what you people speak to the youngsters especially. But then also, I need them to understand that there has to be a balance between, lot of hard work plus personal life. That's the
But
reason I brought in
I
this
want to add
question.
one more thing. See, today's generation is at the other end. I'll work 2 days a week, work from home, no stress. Understand? I said, see, show me a situation where you cannot be without stress. Olympic training, the moment your exam date is announced, there's stress, no?
Correct.
Yes, so actually some amount of stress is important for you to function well.
True.
So you have to find that sweet spot for yours, what is going to happen.
Absolutely.
Or upgrade your brain software to be able to deal with more things. It's like that. It's like one of the common simple examples I give here, because of cricket is a very crazy game. Everybody plays it from top to top. You see, the game is cricket. The ball is the same, the bat is the same, the rules are the same. Whether you play gully cricket or international cricket, the stress is different. But the payout is different.
Right.
But they want payout for international cricket, but they want to play gully cricket. No stress, no thing. How is that possible? So
True.
the message I want to give this current generation is, guys, don't live in a virtual world. It is a real world.
True.
In real world, you have to turn your butt and work. You find your way, but you have to do something. Otherwise, you're it's a liability issue.
Absolutely.
So I don't think there's any way out for these things. And that's whether you work 50 hours a week or 80 hours a week, Sharan Murthy said this, somebody else said this, you decide what you want to work.
True.
See, another thing I tell everybody, I'm sorry I'm taking a little bit more time,
No problem.
is, with all these reservations happening in everywhere, one thing is God has been very democratic. He's given all of us 24 hours in a day. Whether it is Ambani or Adani or Elon Musk or anybody, they have 24 hours in a day. So he's very fair. What you do in the 24 hours is up to you. And how much you generate value per hour in the 24 hours is up to you.
Absolutely.
The more value you generate, the more money you can make. Number one. Number two, every point of success doesn't have to be measured with money.
Correct.
And the other thing I tell everybody who comes, who chats with me is, see, there are 5 things every human being needs in life: health, happiness, peace of mind, love, relationships. I repeat: health, happiness, peace of mind, love, relationships. And all of this 5 money can't buy.
Correct.
Otherwise, why are film actors and actresses depressed? Why are they taking this? Why are they committing suicide? There must be something going on. So that means money is transactional for whatever you do. But you also need these other things going on. So once you decide what life you want and what has to happen there, I think automatically the pieces will fall together, and there's a push and pull. Some days you have to give up something of this,
Of course,
some
yeah.
days you give up something of that.
Correct.
You tell them what is going on. I think it will be a fair plan.
Sure.
Sorry, I ranted a little
No
bit, but
problem.
I thought.
Now, getting
You know?
back to the topic of the episode, what next in movement disorders? Now, we'll do with you first, and then we will come to the surgical intervention.
Sure. So if we want to keep on the surgical track, then essential. So we spoke about the disorders that are, reduced movement, like the Parkinsonian kind of disorders. On the other hand, we have the excessive movement one. The commonest one we see is tremor, shaking. So essential tremor, which is a pretty common condition, it typically runs in families. Now that is another condition that you sort of have distributions, like you either get it around your 20s or later on in your 50s or 70s, a very disabling condition. I mean, some people
So,
have
how
it
do you
mild.
differentiate between the Parkinson's tremor and essential tremor, just for our viewers?
So the Parkinson tremor, by definition, is a resting tremor, but it's not all, you can have additional things. So this postural tremor. So when when you're holding a certain posture, you see your hand shaking. So
Right.
you can also see that in Parkinson's. But with essential tremor, it is mostly an action-related tremor. So it's disabling to the patient because of that. Like
Right.
every time they go to do something, they can't put a spoon to their mouth. They can barely brush or shave or comb their hair because the tremor is just, it depends on how bad it is. It starts off, it is again a progressive condition. So it depends on how bad the symptoms are. Initially, it is managed with medications. Again, you want to make sure that it's not, because there is a caveat here. Now we know from observing these patients for a while that a lot of these, not a lot, some of these essential tremor patients actually transition to Parkinson's. So it's called an essential tremor PD spectrum.
Okay.
So what I do is generally when I'm certain that, okay, this is mostly essential tremor, I still make sure I don't catch any signs on their exam of Parkinsonism. If I do, I tell the patient, I tell them, okay, you know what, I'm catching some mild symptoms here right now. Let me see you back in a few months and I'll check, I'll examine these again. And if after 2 or 3 years, they haven't really developed much, you can be fairly certain that it's not. But I do have patients who have both. So if they are clearly, and then again, you have to ask them. So what if I have a patient who's got an action tremor that's really bothersome, but then you have this, this overlap of, but they also have a rest tremor. You ask which is the one that's most bothersome to them, because you treat them differently. If the action tremor is what bothers them more because it interferes with all their functioning, there are certain standard medications we start with first. We also have utensils now that they move with the tremor. In effect, they kind of cancel out each other. So then the person is able to maneuver, like you have spoons and utensils like that. So we can try all those things. And if none of that works, or, they're having side effects of the medication, it's really disabling, then again, we turn to surgery.
Okay.
You want to talk about that, or...
So, what's the difference that you would look at Parkinson's tremor and essential tremor when you are treating them?
So, just to add to what she said about, so one is ET is familial. So if there's a family history, your father, mother, brother, sister, something.
Sometimes they're adopted, so they don't know.
In your country, I agree.
Yeah. So, but I mean,
Yeah,
exam is
that's-
really important.
yeah.
It's,
Right.
You have to ask that history. Second thing is, in ET, classical ET, when they consume alcohol, it comes down for a few hours. So that's another question that you ask for that. Just these are certain things just to see whether you're muddying the waters, what's going on, and things like that. So then, based on that, you decide if it's drug resistant, he can't sign, checks are being returned, and things like that. Then you have to take action. So again, if even they have bilateral symptoms, some of them only want one side to be fixed.
Yeah.
Because
Usually the
of
dominant side that
dominant
bothers
side
them.
and things like that. So it's purely the hand, one side, or they only want one side. I can do either lesioning, or if they want both sides, we do DBS.
So, if you choose to do lesioning, is it the same area that you would
Yes,
lesion,
it's the same.
or it's a
It's the
different area? It's the
The
same.
target is the same VIM
Okay.
nucleus of the thalamus, so it's the same. So it doesn't matter
Okay.
what's causing the tremor. It does that. So it doesn't matter what the tremor is. We also have other types of tremors called Holmes tremor and things like that. So whatever the tremor is, the location is the VIM, because that's where the cerebellar inputs come in, and so that's what happens. So it's like that. So I mean, the others, whatever I spoke in PD as far as this and that is concerned, obviously they don't have the on and off and all of that.
Right.
The funda is about the same. You have to do your scales, see what's going on.
Got
But what is different if it's classical ET? What's different from PD, though it does progress, the disease progresses. But I think if the tremor doesn't come back in 3 months after surgery, it doesn't come back usually. This is what we have seen. So that's something that we can promise much more stronger than what we promised.
Right. So it's kind of a permanent.
I mean, yes, very rarely it comes back, and I've seen patients 20 years in Japan.
Right.
And what we do also. So it all depends on that. But like I said, if it morphs into something else, then something that we will never know.
Or like you said, you have to hit the spot.
Yeah, and you have to adequately lesion. Because if you do lesser lesion, then obviously
chances of coming back.
So one again to know whether we hit the spot. You know, when you hit the first spot, it should stop.
Okay.
So these are awake surgeries. You know, you're watching the patient.
Yeah, that's
you're seeing. Yeah.
Thanks for saying that. Yeah, it's a completely awake surgery, and then that's what is going on, and it hits the spot, and then we normally stimulate before we lesion just to make sure we're in the right location because it's a blind surgery at the end of the day. So when we stimulate, some of them get a little bit of paresthesia, numbness on the angle of the bone. That's a very good sign. You don't have to panic. Some of these symptoms remain for many weeks after surgery. But the moment you get that, we are very close to that.
So do you tell all this ahead of time to your patients?
Yes and no. When I say ahead of time, whether it is 5 minutes ahead of time or 5 hours or 5 days ahead of time is important because I don't know.
Honestly speaking, if somebody had told me, first of all, I have to be awake and I have to be listening to something and giving a response on the table, I think I would freak out. So did you experience any of your patients that really either freaked out or really had a lot of anxiety, anything like that?
So thanks for bringing that up. So apart from all this I told you about pre-surgical evaluation, this is something that I look for in my patient. What kind of personality is he? Very anxious? And generally over time I've realized I only tell what needs to be told. See, there's a statement we make now, it's important not to tell what's not important to tell. So I tell that in installments. So initially I say, I'm going to put a frame to your head and the local anesthesia, 2 pricks in the front, 2 pricks at the back. The prick will hurt a little bit. After that it will be okay. Then you go down for an MRI. We get the MRI, put it on my software. I plan what's happening. I come in, I give local anesthesia there. You'll be awake. You'll be doing this. I do the surgery. That's all he understands when he comes in. He's okay with that. So when he comes in and then when I finish that, then I'll tell him the next. When I put in the frame, we stick in 2 sticks in the ear. Just before I fix my frame, I say, see, I'm going to stick into your ear 2 times, 1 minute each is going to hurt you. So just before I fix the frame. So he's only, others is how much will it hurt dog? He's simply asking all those questions.
Exactly.
So, and before he knows his stick is out, the pain is gone.
Okay.
So you don't want him to linger on something that's going on. So that has actually helped me to figure out. So then what I also do is I go back and ask them, how bad was the experience? To know whether I can change something. And based on their input, I always say that, it's not as bad as I thought it was, or things like that.
But you're getting information in real time, like you're watching it, the patient is giving you feedback. It's...
That is very important. The live surgery adds that additional amount of stress on the whole operating team.
Correct.
Because, especially if it's a Parkinson's disease patient. So normally, which I didn't say at that time because, somewhere I missed it, was because when we get the patient on the operating table, they have to be in the off phase. Because then we see the best on phase.
Right.
So then they're actually off mode and things like that. So then some of them are very slow in response. So to keep them motivated and do that becomes very challenging, but yet very important. That's when, we have many other things that we have to do.
And sometimes if they're really anxious, you might have to give them a mild sedative, just to keep them calm so they can get through the procedure. So all of that interferes with, that's not everyone.
In some places they've started doing awake, asleep, DVS, this, that. So there are 2 schools. One does awake, one I'm still the awake guy. So I still believe that the feedback is very important because they're all functional targets that we see. But anyway, so
moving next in the movement disorder sector, what is...
So let me, just to wrap up, the ones we use surgical treatment for. The other one is called dystonia. Again, a very different type of movement disorder. So typically you have like repetitive, the word means like a twisting movement because, with every action there is an agonist, meaning a muscle that's allowing the movement. But then you don't want too much movement because then you're going to overshoot the target. So then there's antagonist muscles that are pulling it back. There's always a fine balance that is maintained between these 2 systems. When they're both acting together, that's when you get all these abnormalities. You have tightness of muscle groups, and these can occur anywhere. And this is a very broad topic because when you see a person with these kind of dystonia, so typically you can see them in the neck, we call it cervical dystonia, and that can be, adults can get it. It can be genetic, or sometimes it can be trauma induced. It can be a few things. But if you see younger patients who get it, it's usually a genetic syndrome. So that's where I don't know who if you have like young patients you've operated on, but
Yeah, I see. So there are different kinds of dystonia. So, like you said, dystonia means wrong, abnormal tone. It can affect muscles any part of the body. Depending which part of the body gets affected, we call it focal hand dystonia, we call it segmental dystonia, we call it hemidystonia, we call it generalized dystonia. Neck is going like this, neck back, front like this.
and it's totally out of your control.
Yeah.
Then some of them are going like this all the time. Some of them are going, turning like this. There's a lot of different, even for somebody to watch it is very distressing. Forget about the guy who's going through that movement. And so initially you do medicines, and then they will do, Botox sometimes, toxin. If it's more focal than generalized, you can give it generalized. Then you do genetic evaluation. The key here again is some types of dystonia progress. Initially they start in one area, and then
Especially the
progress.
younger ones, because it starts in the lower limbs usually, then upper limb, and then starts to involve the whole body.
Okay.
Whereas an adult, who starts, say they have cervical dystonia in their 60s, I can manage that with medications and Botox injections for the most part.
And sometimes it goes away. It's very interesting, especially cervical dystonia. For many months they don't have it at all, and suddenly then it comes back, and then so it's like that. So it's not a one size fit all formula at the end of the day, but surgery definitely has a role to play. And leaving the focal hand dystonia, which I want her to talk about before I come back to surgery for that specifically. Any other generalized dystonia, the dystonia is proximal, not here but more here. Again, the favorite target is the GPI, the PTT. So again, we can do lesion if it's one side, or we can put the DBS there.
Okay.
So GPI normally takes more current than STN as far as that is concerned. So which means that before we used to have, non-rechargeable systems where the battery used to die very quickly.
Because it's
And
a
the
much
cost of
larger
surgery,
area in the
because
brain.
a larger nucleus, it needs more current, and plus the dystonia as a disease needs more current for it to get more, more under control. So now with the rechargeable systems, that is better because one, we can do more. It can be recharged every day, every other day, but generally once a week, 5 to 7 days. Those advantages that come with new technology, which is very good for us. So that's how it generally goes. But that's the surgery for dystonia, and again, case selection, target selection, more than target selection, site selection. Site selection is a little easy when it's purely one side. But when it's cervical dystonia, when there's a combination of both sides, especially if it's turned to one side, it's easy. But when it's going like this, like this, and all that, then you don't know. Most of them, they have bilateral components. So you have to mentally prepare your patient that you may need the other side, But what I've seen is I normally promise only 50% result for these dystonia patients. And I say it can also fail sometimes, because it's very complicated, the disease process.
And the patterns can change.
Yeah, patterns can change
over time.
So, but people, even at 50%, they're very happy. They're extremely happy, which is so. What I think is a suboptimal result, they're very happy. Because rest of it, doc, I can manage with medicines and this. So it's like that.
So do you also inform that it can change and you could have
even with injections,
some other kind of symptoms later?
Absolutely, yeah. It can involve different muscle groups. Like sometimes when you've injected for a long time, that muscle kind of thins out. Then that's not the one that's actively causing the problem. It's something else that has compensated in the meantime. So patterns can change, but I mean, for the most part, I've not had many patients whom I've had to refer to surgery for that, because we mostly manage it with
both
injections.
Exactly. When you guess, obviously that's what happens. So I don't even have data how many patients they see.
Right.
We only see the patients that come to us. It's like that. What is the subset of patients that they are referring to us as medically intractable, or whatever the reason is? I don't know. But there is a fair bit of cervical dystonias that I have operated, and more often. And many places don't do DBS for cervical dystonia. Very few centers are doing. So lesioning is a more common thing that we are doing. That's what I do. So that's what it is for hemi also.
So I remember you saying that, in Japan, you used to see a lot more movement disorder cases which came for surgery. Um, what do you think your experience in India is compared to Japan?
No, that is very true. So I don't think it is more common in Japan. That's what I think.
Okay.
See, I've
So
constantly
considering the
analyzed.
population, that we have bigger population in the
I'll tell you,
country
yeah,
and they
I
have
agree.
lesser population, how is that you saw more people there than here?
I think it's
Is
a
it
more,
education?
I
Is
think
it
it's a more advanced
something
economy.
missing?
It's a most advanced community. I mean,
Okay.
economy, most advanced civilization. No question about that. More informed about what their things are, and they go seek help. So Japan is 1/10 India's population.
That's true.
Yet they were doing 5 times or 10 times
Exactly.
what we are doing here. I think it's just like again comes to the saving life versus quality of life. Ili Maya, Mata, black magic. They do all of
Okay.
those things because everything, and doctors also don't know that it has to be referred. Sometimes even the general neurologist doesn't know it can be treated beyond a certain point. Nobody has time to look at it.
True.
Compared to her seeing 16 patients a day, I know neurologists here were seeing 100 patients a day. So, because it's just an overwhelming situation, you can't blame anybody for that. So, in that whole practice, some of them just give up after some time. They never go back to their doctor, so they don't even know what is going on because they think nothing is happening. There's no point going to the doctor. Lot of different reasons. That's why we are trying to do this podcast like this to get that message across to people, that at least come and show up with the right people. I'm not saying that we can treat everybody who comes our way.
Right.
We can give better quality of life, but at least if you come to us, we can give you an informed decision whether you can live with that or
Right.
you can get better with that. And I think that is something that we have to offer, because patients with these diseases don't die in a hurry.
Correct.
They live for 20, 30, 40 years, and that's distressing not just for the patient but also for the family. So I think from that aspect, I think we should be more sensitive to this and try to see what is possible.
I think apart from this podcast channel that we are trying to educate people, the book which is written also contains a lot of these stories
Yes.
which are again educative, right? The rebooting the brain.
I agree.
So, what next? What else do you want to tell our viewers?
I'll just spend a few minutes just to kind of run over the other
Focal hand is one
movement.
thing that we haven't spoken about.
So yeah, I mean, or writer's cramp, as we call it. There are something called task-specific dystonias where you see the hand, posturing, we call it. Like,
Right.
it gets an abnormal posture with that specific task, like writing. They go about it doing everything else, but the moment they start to write, they're not able to do it anymore. So that's a very classic and very amenable to, I guess your kind of surgery, the lesioning that you do. Yeah, disabling, but you probably have a few examples that you recently, or musicians dystonia.
Correct.
Yeah, musicians dystonia. So those are the task specific ones.
So, as a neurologist, what role do you play in these patients? How do you help them?
Yeah, I mean, when I see these patients, first of all, I have to understand, okay, what's the age of onset? Because the age of onset being, if it's younger, the chances that this could become a generalized dystonia is much higher. So then I'm thinking genetic causes and, how do I help this patient? Because quite likely, they will end up with a generalized dystonia. And to treat, to use Botox, if it's a focal dystonia, I can do that.
Okay.
With a generalized dystonia, I mean, I have to rely on medications or, I don't know, maybe surgery. So to educate them to determine what the extent, and dystonias can be part of other disorders, right? Other genetic disorders, like in the young patient, you'll think maybe like Wilson's disease. Those are like different conditions. There's something called Huntington's disease where you can see dystonia. So these are devastating diagnoses to have, but it has implications because they are familial.
Right.
And it has implications for the future generations, so you really need to understand, make them understand what they have. And sometimes you don't get the answer. I mean,
True.
at least the basic, the
True.
genes that we think are responsible, we have to test for those.
You are known as a guitarist surgeon, right? So that is under the task-specific dystonia, I guess. So do you want to say a little about that to
Yes,
people?
yeah. So before I go
And
down,
what else comes under that group?
before I go down, see, this task-specific focal hand dystonia is a very unique subset in the dystonia thing because it's task-specific. It could be a task of writing, it could be a task of playing a musical instrument. I did it for the guitarist, but it can be a violinist, it could be a pianist, it could be a saxophone blower, it could be anybody, drummer. It could be, it can come in the leg, it can come in the hand. I've seen a drummer with a focal hand dystonia in the leg because he keeps pumping the leg and things like that. So that's how it is. So even before that, see, you said what is your role? See, for me, they play a very critical part because what is unique in movement disorder neurologist or movement disorder work compared to any other work is the scans are normal. I
A
don't
lot.
see something structurally problem in the brain that I can fix that.
Right.
It all
Sometimes
looks
it
normal.
takes really long for
Yeah.
something to show up, an
Yeah,
abnormality
and,
to show up.
But many people.
So it's completely clinical that you have
well,
to put your finger on.
There are probably abnormalities, but sometimes it may not show when the person has symptoms.
I'm talking
you know?
especially focal
Yeah.
hand dystonias and
Yep.
things like that. So you see, doing the best surgery on the wrong patient is disaster. So so getting the right
Picking your
diagnosis is
patient,
a big thing that where I owe it to them. So that's why I always say in this field I'm like a technician. Doing the surgery, but it's more them who are actually getting that nuances right. Because otherwise, it doesn't work. So because we don't know which patient is lying, which patient is telling the truth, what's happening. Initially, the symptoms are so vague. It takes us some time for the actual classical symptoms to develop and things like that.
Like
So
if, for PD, if you end up doing it on an atypical Parkinsonism patient,
it'll be a sin.
Right.
it's devastating for them.
So
Right?
that's
So
why in
very-
PD, because she mentioned that, we always say, though there's a concept of early surgery in PD coming in and things like that, early is not less than between 3 to 5 years. You can't do less than that because it takes so much of time for the full-blown picture of the disease to go in one of these directions that reasonably well he's going down one of the paths. One path which is amenable to surgical aspect, other one not amenable to surgical aspect. So that's something that you have to look at what goes on. Coming back to focal hand dystonia. So one was obviously the 2017 guitar surgery that I did after I came back. And honestly, actually, I had not knew there's something called musician's dystonia as a neurosurgeon until I went to Japan. So when I went into Japan, for the fellowship, the only thing I thought functional neurosurgery was DBS for PD. That was the commonest thing that I knew, and that's what was
And I think
common.
epilepsy also.
Yeah, but in movement disorders, I'm talking movement disorders. And I would go into the OT there for the first case on the first day. I had checked in on the weekend, so I had not done the the pre-op discussions on the case. And I go in a little early because I was, new. I didn't know, with Japan language, all of those things. And they said, go to OT number 5. I entered the OT alone, and there's a big piano in the OT. I said, what's going on here? I just quietly came and sat in the, changing room, waiting for the local fellow to come. He came and I followed him inside. He went to the same OT. And he started sort of getting ready. And after 5 minutes, I took the courage to ask him, what is this piano doing here? He said, she had pianist dystonia. I said, what? Pianist? Oh, she said, my goodness, first time I'm hearing. Can you imagine me as a neurosurgeon? And then that lady is playing the piano in the OT and he's doing the video thalamotomy. I said, whoa. I sent her the video. I said, this is a different world that I've got into. What's going on here? Because I had not heard this, even in many of the movement disorder conferences. And that's how it was like a baptism by fire, if you ask me, for what was going on. So then I came back and learned this guy. He called me once I came back. My hands, then I started presenting to everybody that I knew. Well, I got my videos from my professor. And this hand surgeon, orthopedic hand surgeon, had this guitarist who went to him and said, go meet Sharan, is doing something. So he called me on the phone and asked me, I heard you do some surgery for, and I have this guitarist dystonia. I said, I do brain surgery. He said, thanks, and put the phone down. And because he and his family thought I was nuts to undergo a brain surgery for a focal hand dystonia, and he was an IT professional. But 10 months later, he started having difficulty in typing. And because on the computer, that's when he came to me. I did the surgery and rest is history. Because actually the video that went viral was not my video.
Correct.
I allowed the wife to come into OT. To the end of surgery, she shot it on her phone and she posted it on her Facebook page. And before I knew, it was viral all over the world. It was like crazy. After that, since then, I've done 3, focal. I think there are more difficult things we do, like writer's cramp. But somehow the press likes the guitarist
Right.
that gets picked
More
up.
glamorous, I guess.
Well, I did a young doctor recently. I think you also saw him. That guy was the first reference I got from the book we wrote. That's when
Okay.
a doctor referred him to me. This guy's been having writer's cramp for nearly 7-8 years, and he passed his MBBS exam using a scribe because he couldn't write himself. He was that bad. And then he loves playing video games. And the joystick, if he starts pressing with the finger, the finger would go into tremor like this. So he had a tremor, he had a writer's cramp, And if he writes half a page, his hand doesn't move for the next 3 hours. And you know what?
Shoulder also here.
Yeah, what is very interesting, this is not paralyzed. Everything is normal, only when they do the task. And then he started developing this movement in the shoulder. So this was probably the most complicated case I did, because he had a proximal dystonia, he had a distal dystonia, and he had a tremor.
So what was the target you?
So I did all my discussion thanks to my training. I did an anterior WIM, anterior and posterior VO, and he did a PTT. He did all the 3, the 9 lesions, and you saw him.
Because of the extent of
so I had to
involvement.
target, because see, there's something called somatotropy in the brain. We have the motor strip or whatever, and as it goes down, the somatotropy continues down. It's so beautiful the way it does. So you need to understand that logic. Once you understand the logic, where the hand is, where the leg is, where this is, where that is, where the tremor circuits are going, where this circuit is going, then you catch that. And that's how they get better. So I think that's why this field is so fascinating.
Sure.
All of this. I can keep talking about this, but I think I should stop.
So, have you had any funny experience with your patients? I mean, when they've come to consult you or anything like that? Funny questions, funny experience?
Not really. It's a pretty serious clinic all the time.
Okay.
I'd like to have some fun, but
We will send you some fun from India, I guess.
yeah, probably not.
No?
Yeah,
I'm
because by the
sure
time
you have a
by the
lot.
time they come to me, they've already seen, their primary doctor, they've seen another specialist, and then unfortunately, well, not unfortunately, but there's so much information available now
Right.
that by the time they see you, they've already read so much about it, and they've already thought the worst of everything. So by the time I'm seeing them, it's pretty serious discussion.
Okay.
I mean, I try to keep my, I try to keep it easy, but I think it's combination of, the kind of disorders we deal with, right? A lot of them are degenerative, prolonged.
They
And
also have
then-
suffered for so long.
Yeah,
and
without a
Yes.
diagnosis, so they just didn't know what to do. And then along with that, like caregivers, the caregivers who come in, like there's so many questions and there's so many things they need to do. Caregiver stress is something also I deal with a
Absolutely.
lot in my clinic because of the conditions we treat, and maybe you can elaborate a bit more on that. But
Yes.
trying to balance everything, there is it's always like the patient, they don't want to complain too much because they're like, I don't want to stress out the spouse.
Right.
But then the spouse is arguing, okay, if they don't tell me, how do I know? Right? So there's always that there's two sides of that. And you're the one trying to balance everything.
Yeah.
You want them to tell them the symptoms so I can do something. But at the same time, trying to explain to their caregivers, like, how do you manage? And typically, persons with dementia, that's where this really
I think
sort of,
impacting.
yeah. So to
So the
answer your
caregivers
question, no.
in my
No fun.
experience, I think I've had people saying that you're the first person who asked about me, because everybody focuses on the patient, right? The caregiver is also supposed to focus on. It's taken for granted that
Right.
caregiver's job is to take care of the patient. Right, and unfortunately they are forgotten. So when I ask them, how are you? I mean, did you eat food? Did you get to sleep last night? They say, first time somebody is asking
Right.
if I did something.
If I
So,
I sense that,
it says volume, right?
and sometimes they don't want to say it in front of the patient because then they'll think, they have that
Absolutely.
guilt. And so sometimes I do talk to them separately to kind of get a sense, and if they need any help.
It's so required.
It's not easy. It's not
Absolutely.
easy to be available 24/7 to someone like that. So
True.
So
Do you want to?
No, so the truth is, no, you see, we see the patients for a very short period of time, an X amount of time, very surgically, stitches removed, wound heal. Otherwise, it's, really them who
Yeah.
are, really taking the whole thing. I need to appreciate them, the kind of patients they should have, the way they have to manage and things like
Correct.
that. So the least I can do to make their life better is to target properly and make sure I do the right thing so that then they can
Get them the result.
yeah, they can sort of work with the best possible thing that is there, because they sent because they had a medically intractable thing.
Right.
So if I don't add to value to what they're doing there, then it's unfair for what is going on.
Right.
So I think that's where the partnership has to work very well to make it happen. But that's my message.
That's true. Okay, now to wind up this whole thing, this program, I think it was a really power-packed information session. I think for our viewers, they've really had a lot of information. I think it was too short a time for too many information, and some of it was, I think, a little technical. I guess forgetting all the technicalities, the information both you guys have given, I think it talks volumes about what experience you have. And also, guys, you have to like, subscribe, and share this with all your friends, because this is not information for 4 people, right? It is information for the world. So go ahead and do this as much as possible. And to wind up, do you have, both of you, some kind of a parting words for our viewers?
Ladies first.
You want to go first?
I think keep it simple is what I want to say. I mean, a lot of the disorders we see today are lifestyle disorders. Like even if you take dementias, you take Parkinson's, outside of the medications and everything we're doing, it still comes back to, what you're eating every day. Are you moving every day? Other lifestyle issues like smoking, managing metabolic issues like high blood pressure, diabetes. Again, that comes back to simple things.
True.
So I honestly believe that a lot of the power is still in our hands. So what if you have a neurodegenerative condition? There's a lot of things we can still do. Like even though I have a Parkinson's patient who needs 4 different medications, I still recommend they exercise every day because there is benefit. There is benefit to that. I mean, keeping other comorbidities in mind, I think there's certainly things we can do. So try to eat healthy, move as much as you can,
Lalit, do you have something to add?
Yeah, all I want to say is, as much as there's a level of resignation, cynicism to a degenerative process that, it's not going to get better, I have to live with this and all of that, I want to tell them that surgery is not the last option. Surgery is not the worst option. Surgery is a good option, the right kind of patient. And none of us can operate if they say no to that.
True.
So just because the neurologist refers to a surgeon doesn't mean I'm going to put him in and operate him. It is good for them to actually evaluate all options in front of them and then take an informed decision whether they want to go down that path or not. And I think at least they'll be at peace to know that I've tried all the options,
Correct.
I've chosen what best I can,
Correct.
and then learn to live with peace with what they have,
Sure.
so that at least, their mental health is much better. I think that's the way it is. And especially once, we get put devices, a doctor and patient is married for life. That's something that, that's also something that they have to understand. And it's not like a cold cough fever treatment, they come for 5 days, then they go away. It's not like that.
Right.
That's what it is.
Right. Viewers, you've been watching us for so long, and I know it's a lot of information. Keep watching our channel, and we are here to get you a lot of information, lot of education material, so that 1, you educate yourself. 2, share it with a lot more people so that we educate everybody else. Whoever needs us gets the help. Thank you so much. Namaste. So here is your book. Please do read
Thank
this
you
and
so much.
give us a feedback.
Thank you. I will.
Healthcare tourism. It is so much so I think they have a ministry of healthcare tourism.
Correct.
Right? Is the most pejorative term ever made. Like there's so many Indians who go to New York or Harley Street. Are they going for tourism? No, they're going for treatment. All these fellows who are coming to India, are they coming for tourism? No, they're coming for treatment. They get cost-effective treatment.
Correct.
Tourism is a word which was created in the West because
To
they
belittle this.
to belittle this.
And we
And
fellows
we have
fell
been
for
very
it.
happily adopting it and putting it up, stamping it on our head saying, I'm Minister of Medical Tourism.
When you look back and see many people who have done, not so good in the academically, because the marks is only just a number. I've always said, how can you evaluate somebody just on a number? It's never made sense to me. but we had to play the game, you max it up and things like that. What is your take on these marks and these exams and all of that?
Do we really need examinations? Because the need of an
profound
examination is not the student's need. So somebody once compared this to, you have a plant in a pot, pulling the plant out to inspect the roots, to examine the growth.
What an analogy.
Yeah, because the trauma of the examination process has turned off many people from subjects like maths and all that.
Even medicine.
Yeah, because you fail once or twice and you get turned off. In India, somehow the powers that be have thought of sending a doctor out to space and solving medical problems in space, which never works.
Correct.
Right? Like they send him to rural areas and he's there in the rural area looking here and down, watching the birds fly. He doesn't know what to do.
True.
It's like sending
and he's wasting his time.
It's like sending an electrical engineer into the village and saying, solve all electrical problems.
There's no electricity.
There's no electricity. Sigmund Freud's famous line to Einstein saying, war is biologically sound. I don't know if you
I haven't heard this.
So there was a lot of correspondence between Einstein and Freud.
Okay.
Because they both saw World War I and went to World War II. So Einstein wrote to Freud saying, having seen the devastation of World War I, why is the world rushing towards World War II? And Freud came up with that brilliant line saying, war is biologically sound. And his justification was that we are basically carnivores, warm-blooded, so we need a kill. So that he calls the mortido instinct. Right? And in addition, we sublimate this instinct because I can't go around killing everybody. I verbally best you. We choose head of departmentships here by accidents, by serendipity. That is, you're the junior most person, but you're the only neurosurgeon, so you're head of department.
That's what is happening, and a lot of people put that next to their...
You're the senior most person, so you're the head of department. Then somebody
It's
says...
more time-based or just location, whatever based.
Serendipity. And suddenly somebody comes with a new rule saying in Holiday Institute you're having rotating headships. So who's the next guy? Rotate him. Without any planning.
And no logic.
No logic. The better system would be that, let us assume you want a rotatory thing every 5 years. At the end of 5 years, you call for interviews of every eligible person and say, look, give us a game plan.
Next 5 years.
Next 5 years. If I have regrets in life, and I have many, it is that I have not stood up for myself.
What do you mean? I mean,
like
can you tell
many
our global
times,
viewers what that
okay,
means?
let's say you have a patient, okay? You're a relatively junior person and you're convinced this is the way to do it. But you say, okay, I'm standing in the front of so many senior people. And who am I? So you back out. And what you thought actually transpired. Patient dies. You regret it. You can always back out saying it's not my responsibility. I'm just a student. So I was not called to. It's not my call to make.
Correct.
So it boils down to the fact that you didn't have the guts. You didn't have the courage of your convictions to stand up. And then the last message, if there's messages, the point is the skill sets needed to get ahead in politics administration are also different. Like nobody who's heading a hospital necessarily knows neurosurgery. So he would then ask people for advice. So whom would he ask for advice? So he would ask you, why? Because you are a great neurosurgeon. Over the last 20 years, you have a superb track record. But you too should realize that you're not now in the cutting edge.
Correct.
The cutting edge is the next generation. So
Correct.
Again, I bring it down to a war analogy. The advisor to the defense minister is a medaled general of the last war, of World War II. He doesn't know the reality of the ground
Now
of
it's
World War
cyber
III.
war for all
It's
you know.
cyber war,
Yes.
and he's clueless.
Yes, he's clueless.
Right? But he is advising the ministry.
Amazing. You're right.
So put these three together and you can have the beginnings of change.